Boston City Hall and Boston City Council chambers. This is a hearing on docket number 0819, the impacts of medically supervised injection facilities. I am Boston City Councilor at Large Anissa Saibi George, chair of this committee, the Committee on Homelessness, Mental Health, and Recovery. I'd like to remind everyone that this hearing is being recorded and broadcast live on Comcast 8, RCN 82, as well as streamed online and replayed for further viewing. I ask that you please turn off your cell phones or any other devices that make noises. Also, if you haven't already, please sign up for public testimony. There are sign-in sheets by the entrance. If you'd like to testify, please check the box, and we'll have you for public testimony later in the hearing. Today, we are going to be discussing a very controversial topic, medically supervised injection facilities. I'd like to remind everyone that this is a chamber in this chamber, the point of the hearing is to learn as much as we can, and that means we need to hear from all sides. Out of respect for everyone here, I expect that there will be no applause, no signs, and absolutely no use of stigmatizing or derogatory language. We will hear from everyone, and we will also hear first from two esteemed panels. Each panelist will present to the counselors and have an opportunity to ask follow-up questions. We will then start with public testimony. If you have checked, you will be called up in the order of arrival. Please keep your remarks to no more than 2 minutes if you can. You may also submit written testimony, which we've received quite a bit of. We are facing an opioid crisis. Opioid overdose is the #1 cause of accidental death in Massachusetts, claiming nearly 6 lives every day. As our region's capital, not just for the state, but for the region, Boston is on the front lines of this battle. We have to be proactive and to make sure that we are part of this conversation. There is one happening at the State House regarding medically supervised injection facilities, and this conversation should not be happening without the city at the table. We are the key stakeholders, and that's why we are here today. I look forward to a very productive and respectful hearing and want to thank my colleague, Councilor Frank Baker, for his co-sponsorship of this legislation for this hearing order on this issue. I'd also like to recognize, in order of their appearance, Councilor Tim McCarthy, who's the vice chair of this committee, Michael Flaherty, at-large counselor, District Councilor Josh Zakem, District Councilor Mark Siomo, District Councilor Tito Jackson. I have also received a letter from Councilor for District 4, Andrea Campbell, who is regrettably unable to attend today's hearing, but will certainly, she says, review the video and look forward to participating in further discussions. So I do, with our panel, I don't know if you've got an opening comment, we'll go right to the panel.
Yeah, we can go right to the
So we're going to go right to the panel because we do have a large crowd today and lots of public testimony. So we want to be as efficient as possible with our time, and I do remind everyone that this is the initial conversation. This is the first conversation. So there'll be many more opportunities to discuss. So with that, we have, and if we could just go through and introduce ourselves, but I have first on my list Dr. Henry Lawrence Dorkin. If you'd like to introduce yourself for the record. Right, thank you. Sorry, I know I introduced myself and I got mixed up. If you'd like to introduce yourself for the record and get started, that'd be great.
Thank you very much. My name is Hank Dorkin. I'm a pediatric lung specialist practicing in Boston, and I'm president of the Massachusetts Medical Society. And I first want to thank the chair and the counselors for having this hearing. I think it's very important. We at the Medical Society are concerned about the opioid crisis, as is everyone. And so on the first slide, this shows 3 different blocks of the opioid crisis as average annual opioid-related death rate per 100,000 in the Commonwealth. The first to the left is 2001 to 2005, 06 to 10, and the final from 11 to 2015. And unfortunately, as you can see, the areas around the state in blue and dark blue signify where we are having a problem, and it is pretty much everywhere that we're having this issue. In order to help mitigate this epidemic, the Medical Society has worked for the past few years to address prescribing habits as well as education of physicians and patients. For example, we offer free continuing medical education modules that have been used by 10,000 physicians, nurse practitioners, and other prescribers. We've worked hard towards partial fill legislation, education of our medical students and dental students, and reduced prescribing. Our focus has been to prevent dependency where possible, and to some extent the efforts are working. Between the beginning of 2015 and 2016, we saw a more than 20% drop in the number of opioid prescriptions. But the epidemic, unfortunately, continues. While the fractional increase in deaths has been slowing, the total number of deaths has been increasing each year to the point where we lost 2,000 citizens from the Commonwealth in 2016. This is what a supervised injection facility looks like, and basically these are considered harm reduction facilities to try to reduce overdoses and other harms associated with illegal drug use. It's a legally approved public health facility that offers a hygienic environment where people can inject previously acquired illicit drugs under the supervision of trained staff who will intervene if these people get into trouble. Importantly, SIFs do not, under any circumstances, supply illicit drugs to the patients. These are drugs that the patients have themselves, and were it not for a facility like a SIF, would be injecting somewhere down a dark alley without any support around them. In 2016, the Medical Society House of Delegates felt that the MMS should perform an internal evidence-based study of the ethical, legal, and liability considerations and feasibility of a medically supervised injection facility in Massachusetts, with a report back to the Board of Trustees and the House of Delegates no later than A17, which occurred recently in April. And we tried to spare no opportunity. We were in communication with people in other parts of the world who are doing SIFs, and other parts of the United States that are also considering it, although currently there is no approved SIF anywhere. But we felt that the data were somewhat compelling. If we look at the Vancouver data, the overdose mortality decreased by 35%. If that were comparable in Massachusetts, of the 2,000 that we lost in 2016, 700 people who died would not have died. And these are mothers and fathers, sons and daughters, sisters and brothers, spouses, all of whom would be alive. And in fact, there was a 30% increase in the rate of people entering detoxification, increase in methadone maintenance initiation. There were no reports of negative consequences to the communities, and in fact, several of the groups that at first were reluctant to see this go through in Canada, namely people in the local communities and the constabulary, when it came up for renewal, they were among the strongest supporters, because deaths were down, the distribution of paraphernalia and drug litter was decreased significantly, there was less crime, and in fact, a recent study at Johns Hopkins found that there would be a significant decrease in medical care costs. They found that an annual cost of $1.8 million for a single SIF, it could generate $7.8 million in health care savings in the city of Baltimore alone. There is little change in drug deals. There's no increase in crime. And our staff has spoken to the medical officers in Vancouver. They said in the area around the SIF is not only better, there has not been one death related to people who are using the SIFs. And the data and support continue. At the annual meeting of the Medical Society, the report was approved with a vote of 193 to 21. And so, therefore, we felt that this was something that we should approach the state and the city with, in order to put together a task force run by the government in order to figure out, first of all, if what we have found in this report is applicable in Massachusetts, and if so, where would be the appropriate places to consider a pilot project. But clearly, this is something where we still need to generate more data and more information as best we can, and that this would be a collaborative effort. So where do we go from here? I think that, as you stated earlier, this is fact-finding, and there's a lot more information to get, but we hope that people will use the 69-page report that our task force under Dennis Dimitri and Jim Gessner put together as a basis for further investigation. Thank you.
Thank you, Dr. Dorkin. I probably should have started, I'm sorry, with our Executive Director for the Boston Public Health Commissioner, Monica Valdez-Lupi. I don't know if you've got a presentation to share, or if Devin Larkin, who's the Director of the Bureau of Recovery Services, would like to go next.
Thank you. Good afternoon, Councilors Asabi, George, and Baker, and members of the committee. My name is Monica Valdez-Lupi, and I'm the Executive Director of the Boston Public Health Commission. And as you mentioned, Councilor, I'm joined today by Devin Larkin, who serves as our Bureau Director for Recovery Services. Thanks very much for the opportunity this afternoon to provide testimony for today's hearing. As you know, and as you've already highlighted, the crisis of substance use disorders is one that many cities and towns in the Commonwealth and across the country are grappling with and trying to look at a whole range of different interventions. Strategies need to look across the continuum from prevention to treatment, harm reduction, and ultimately recovery services. The crisis of substance use disorders in our city is a challenge that has required creative thinking and strong partnerships, and I share Mayor Walsh's deep commitment to addressing this challenge. I wanted to share some data that we gather at the health department to just provide some additional context to what we're seeing in the city. Cancer was the leading cause of premature mortality for Boston residents from 2011 through 2015. Heart disease was the second leading cause of death between 2011 and 2013, but was replaced by accidents in 2014. Accidents include unintentional drug overdoses. In 2015, unintentional opioid overdoses accounted for 71% of the deaths due to accidents for residents under the age of 65, and would rank third if explicitly specified within our ranking scheme in terms of these health conditions. My colleague Devin Larkin will go into more detail around the existing services offered for people seeking recovery, as well as the significant prevention efforts the city is engaging in, but I wanted to touch on some of the achievements we've made to date. The FY17 investment from the city to expand the PATHS program through integration with 311 doubled the number of weekly PATHS contacts and consequently increased our capacity to make connections to vital recovery services. We now see between 130 and 150 visits each week and are still averaging 4 to 5 new clients each day. Mayor Walsh and the administration also invested in a new neighborhood engagement team of 4 staff who conduct street outreach, overdose prevention education, and connecting individuals with street outreach and recovery services and shelter in the Newmarket Square area. The team works 7 days a week from 8 a.m. to 4 p.m., including holidays and during bad weather. Since the program began last summer in August of 2016, the team has completed over 12,000 engagement activities, which includes the number of hours spent on street outreach, number of people that they've engaged with, and number of people actually offered services, including over 800 referrals to shelters and treatment programs. In addition to our PATHS program and street engagement, there were many other accomplishments. We delivered over 600 opioid overdose prevention trainings and collected 13,000 syringes from public spaces. Lastly, on behalf of the Health Department, I'm really pleased that Mayor Walsh has provided strong support for our FY18 initiatives. We have a new initiative that I wanted to highlight in terms of PATHS, which will now extend our hours of operation to 7 p.m. on weeknights and 9 a.m. through 4 p.m. on weekends. Increasing our hours of operation will strengthen our work to ensure that the system is as easy to navigate as possible for those who need it. In Boston, we're committed to fighting the opioid epidemic and providing critical addiction and recovery services. I'd now like to turn it over to Devin to share some more details about our different programs and services. Again, thank you for the opportunity to bring us all together to speak about this important issue.
Thank you, Monica.
Good afternoon, councilors and members of the committee. Thank you for the opportunity to provide testimony for today's hearing. A core function of the Boston Public Health Commission is to provide critical addiction and recovery services. As we know, opioid addiction is a national epidemic, and Boston is at the forefront of its treatment efforts. The city of Boston has a robust system of care for individuals, families, and communities affected by substance use disorders. We work to make sure the system is as easy to navigate as possible for those who need our support. In partnership with an excellent network of community-based providers throughout the city, we offer programs and resources aimed at supporting the treatment and recovery of those impacted by addiction. We've found the best way to tackle the issue in Boston is to work collaboratively with neighborhood associations, nonprofit groups, treatment providers, and partners across multiple city and state departments to ensure that we can best provide a comprehensive continuum of services. The Mayor's Office of Recovery Services and the Bureau of Recovery Services has partnered with Boston EMS, Boston Police, and Boston Fire to engage with residents post-overdose and to provide harm reduction and access to care services to them in their homes. As Monica mentioned, for the last 9 months, 4 outreach workers have been walking the main roads and side streets around Melnia Katz Boulevard 7 days a week, engaging with vulnerable individuals and helping them access the services they may need. On a given week, they may have 500 client contacts. The city has also integrated existing recovery services support into the mayor's 311 hotline, creating a 24-hour hotline where people can access information and seek treatment and recovery support. The 311 hotline integration has led to a 50% uptick in client interactions. We remain committed to providing a full scope of services to active users, including referrals to treatment, naloxone and overdose prevention, HIV and HCV testing, and needle exchange. The goal of our work is to provide these services in a way that is safe, reduces harm, and engages individuals in comprehensive services and support. Thank you for the opportunity to speak. Please let me know if you have any questions.
Thank you, Devin. Might as well go to Aubrey next, please.
Hi there. Thank you for inviting me. My name's Aubrey Esters. I'm a member of SIF-MA Now. It's a community organization devoted to opening supervised injection facilities in Massachusetts now. I'm also a person who uses drugs. I'm also a resident of Boston. I support the Boston City Council, and I encourage you to support SIF for a number of reasons, and I'll give you two right now. I'm wondering if the slideshow that I had prepared is playing. Oh. No. Okay. Well, I'll go on. So these are my two main reasons for why I support SIFs. I'm a person who uses drugs who would use a SIF right now if it was available. My safety net, as of right now, consists of doing a slow shot, testing for fentanyl before injection. That's not mine either. Testing for fentanyl before injection and immediately after injection, and continuing to text back and forth for a few minutes with a friend to ensure that someone would know that I overdosed.
Aubrey,
if
if you
that
want to just
happened.
hold for a second, I think we're almost there. No.
No.
Is that,
No.
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 If you want to, just so we can see if we can pull it up in the meantime.
Sure.
I think, Nadine, will you see where that is? Thank you. Aubrey, do you want to just hold and we can go to our other panelists?
Yeah, that'd be
And come
great.
back, that's okay.
Thank you.
Thank you. So we have, if you doctors would introduce yourself for the record, thank you.
Thank you, Aubrey, for yielding your time. Not your time, but hi, my name is Gabriel Wishick, and I'm a primary care physician and addiction specialist at Boston Healthcare for the Homeless program, which for over 30 years has been caring for the homeless in shelters and on the streets here in Boston. Drug overdose is now the leading cause of death among our population. And as such, we have come to believe that we need to strongly support the development of medically supervised injection facilities, or SIFs, as a vital tool to help us combat that epidemic. I want to extend our heartfelt gratitude to Committee Chair Asabi George and Councilor Baker for co-sponsoring this hearing and for the opportunity to provide testimony. We're also deeply grateful to the city for its leadership in confronting this devastating epidemic. Boston is so fortunate to have a terrific needle exchange program, unprecedented access to naloxone, and a wide range of high-quality drug treatment services. As some of my fellow panelists have mentioned, this epidemic is really increasing in Boston as well as elsewhere. Fatalities in Boston were 3 times the size of any other city in the Commonwealth last year. And part of that is due to the mixing of synthetic opioids into the heroin supply. And despite our best efforts, this is a changing epidemic. Our current established strategies simply have not been enough to address this crisis and reduce deaths so far. In this context, our organization has expanded our outreach to active drug users who are at high risk of overdose. For the past year, we've operated a recovery room that we call the Supportive Place for Observation and Treatment, or SPOT, where people who are already oversedated can come to be medically monitored and connected to further treatment. We opened SPOT out of desperation, to save lives, and to engage with people who are actively using. In the first year at SPOT, we saw about 500 high-risk users in nearly 4,000 encounters. Our efforts have avoided, we estimate, around 1,000 emergency room visits and have likely saved lives. We are also proud to report that 1 in 10 of the very high-risk people that have used SPOT have been directly connected to treatment from that encounter. Yet what we're learning is that SPOT is not enough. People are dying before they can get to medical care. We've come to support a strategy that 11 other countries around the world have pursued since as early as 1984. In the decades since, over about 100 peer-reviewed studies on SIFs have been conducted. I want to share with you what the evidence tells us in answer to about 5 questions, drawn from our local research and from the literature on this subject. 4 of the landmark studies on supervised injection are included as part of our written testimony. Number 1, can SIFs impact overdose deaths? Yes. As Dr. Dorkin has shown, there's a study in the Lancet on Vancouver's downtown and saw that overdoses decreased by about a third within 2 years of opening their SIF, compared to an insignificant change elsewhere in the city. We are desperate to see our own overdose rates drop by that rate. SIFs can reduce overdose deaths. Number 2, can SIFs be a point of entry for detox and treatment? Also yes. In fact, they can increase users' entry to treatment. In a study published in the New England Journal of Medicine, people who used their SIFs most often also got into detox most often. Those SIF clients who had any contact with the addiction counselor at their SIF got into treatment much faster than those who did not. In fact, yes, SIFs can increase referrals to treatment. Number 3, do SIFs encourage drug use? I want to echo what Dr. Dorkin said, and no, there's actually several studies that have been done on this issue. In one from the British Medical Journal, researchers showed that the patterns of use were unaffected after opening a SIF, impacting neither relapse for those in sobriety, nor really significant reductions among active users. And another study in the American Journal of Public Health among clients of a SIF showed that SIF was not a factor in their drug use initiation. I think this really addresses some of the fears that we have among us about SIFs and shows that they do not actually encourage people to start using or to relapse. Number 4, what impact do SIFs have on their surrounding community? I think the research suggests that they have either a neutral or positive effect on public order. And again, in Vancouver, they found that when the SIF began, afterwards, they found less public injecting and less publicly discarded both syringes and other drug use equipment. We recently conducted a survey in the South End and showed that there's a high burden of this type of blight in our neighborhood. We think that a SIF could really lead to improvements in public disorder. And number 5, do people want a SIF? Our preliminary data shows that Bostonians who use drugs really would use a SIF. I can elaborate on that in questions if you'd like. We also have a local survey that shows that about 1/2 of South End residents thought that a SIF was a good idea. And this was done over a year ago prior to this issue really making the headlines. I think the research is actually quite clear. SIFs save lives, and they benefit both individuals and communities. Now more than ever, we cannot wait for people suffering from addiction to reach out to us. We have to go to them at the point of injection, even if it's difficult. The time between an injection and its deadly effects has shortened so much that people are dying in seconds and minutes before help can arrive. This is a clear treatment gap, and one that we cannot close if we only focus on recovery services. SIFs really play a key piece in the continuum of care for this chronic and relapsing disease, and they exist to keep people alive so they can make it to further treatment. I think we desperately need that option here in Boston.
My name is Joe Wright. I am also a doctor at Boston Healthcare for the Homeless. I'm the medical director for our office-based addiction treatment program. I'm an HIV specialist, and I provide general medical care. I want to echo Dr. Wishick's appreciation for this hearing, for the opportunity to testify. Counselor Sabi George and Counselor Baker, thank you for sponsoring this. Many people in this room know how strong a force addiction can be, how people keep using a drug like heroin despite bad things coming from it. Dr. Wishick has given you some data. In the second portion of our joint testimony, I'm going to talk about a story, one story among many, of that time of injection that Dr. Wishick talked about. For one patient of ours, a 26-year-old man who I'll call Mike, he had come to Spot many times. He would come to us sedated but breathing. We kept him safe. We kept him alive. We got to know him. Even as he kept using, he started trusting us, knowing we cared for the person he was and not just for who we wanted him to be. When he decided he was ready to stop using, he came to us. At the same moment, probably around the time Mike told us he was ready to stop, some lab somewhere in the world was producing a particular dose of fentanyl. Fentanyl is much faster acting than heroin, and it's about 50 times more potent. It can be produced anywhere someone can set up a lab with no poppy fields required. Fentanyl and even more potent fentanyl derivatives are outcompeting heroin in the drug economy, either getting mixed in with or simply replacing heroin. Heroin has always been dangerous, but heroin mixed with fentanyl or replaced by fentanyl is much more dangerous. And in this story, as Mike started thinking about next steps, a small amount of fentanyl powder was moving towards its eventual destination. Our staff got Mike into detox. In a transitional program, he put together 6 weeks of sobriety, but then he was discharged to the street, and it was too early. Mike started feeling that pull. He came back to Spot. He said he was about to use. He knew his tolerance was low, so his overdose risk was higher. He looked for people he knew, but he couldn't find a friend to come with him to administer naloxone if he needed it. One of our nurses warned him how much danger he faced. She talked to him about treatment. She gave him naloxone to carry with him. He left. She worried. Meanwhile, that fentanyl had traveled to multiple middlemen who probably diluted it a bit, mixed it with heroin or didn't, and moved it to a street dealer in Boston who may have or may have not diluted it more. No one was using the kind of precise pharmaceutical manufacturing techniques that allow hospitals to use IV fentanyl for rapid sedation. The margin of error was big enough that even if Mike had taken our nurse's last desperate advice of at least doing a small test dose, he might have overdosed even from that. Mike's situation of injecting after an extended period of not using has always been a dangerous moment for people who use opiates, and fentanyl makes that moment much more dangerous. When Mike died, it was likely just a few minutes later. He was found dead an hour and a half after he left our building, just a couple of blocks away, in the shadow of a world-class medical center and a large needle exchange program with a Narcan kit at arm's length. If Boston has been especially hard hit by this epidemic, Boston also has a unique opportunity to lead in its creativity and its compassion. We hope for a city without the private shame and danger of people suffering and dying alone. We believe in bringing people out of the shadows and into our collective embrace. In our vision, we don't have to watch Mike walk away and die. In our vision, we say, no matter what, we'll be here with you. Counselors, thank you on behalf of Dr. Wishick and I for the opportunity to speak today and for the opportunity to contribute to this important conversation.
Thank you.
Thank you very much. Aubrey. Thank you.
Do-over. So, while I'm speaking, I'm going to show some faces of people who live in Boston who support supervised injection facilities on the screen in the background while I speak. And a lot of them are people who use drugs. My name is Aubrey Esters. I'm a Boston resident, and I'm a person who uses drugs. I encourage the Boston City Council to support supervised injection facilities for a number of reasons. Here are two. I'm a person who uses drugs, who would use a SIF if it was available. My safety net right now consists of doing a slow shot, testing for fentanyl presence with a strip, and immediately after injection, and immediately continuing to text back and forth for a few minutes to ensure that someone would know if I overdosed and may hopefully get to me in time to save my life if something went wrong. I overdosed a week ago while alone. And since I didn't want to bother my friends, I didn't use that safety net. The result was a near-fatal overdose where I lost hearing in both my ears for 12 hours I still haven't fully recovered from. I got lucky that I survived, but this doesn't need to happen, especially not in a city like Boston that's so committed to public health. A second thing I'd like to say, and my second reason I'd like to bring up today, is because I've lost far too many friends, loved ones, and peers to accidental overdose in the past 12 years. Their names are etched in my mind, and their faces are ones I'll never forget, especially the faces of my people, those blue and purple faces gasping for breath in alleyways and bathrooms because no one cared enough to make sure they survived, and people perhaps didn't think they fucking mattered. Excuse my language, I'm sorry. I remember one day A group of folks injected together in a bathroom apartment in Boston, and one man in a wheelchair overdosed. And the only person who was capable of responding simply rolled him out the back door into the alleyway to die alone. The rest of us found out the next day, but there was nothing we could do. I never knew his name. The evidence supporting SIF is clear. The only objections are moralistic ones, and in my opinion, personal morals don't belong in public health policy. Thank you for your time.
Thank you, Aubrey. So at this point, we'll do opening statements and questions from my colleagues. I'll start with Councilor Baker.
Thank you. Thank you, Councilor Wasabi George. I guess I'm forming my opinion on SIFs now. My concern is more, I think, that through the reports and through talk that you hear, and it's always unofficial talk, is the talk of the Southampton corridor being a great site for SIV. I'm the city councilor down there, and I have a hard time thinking that it will be helpful to us down there, and I'm still not convinced by your testimony, like not even close, that it will be helpful. Some of the issues that I have is there doesn't seem to be any endpoint for using these sites. Like you have in Vancouver, I have some data from the Vancouver Coastal Health, 263,000 visits a year by 6,500 individuals, and it has only 464 referrals to on-site detox. That doesn't seem like great numbers that we're actually, okay, you're going to use this and then for X amount of days. I just think I have a very difficult time if there's not an end date on this use. Like maybe if it were part of an entire facility over on Long Island, okay, you can go over there and you can use for 3 days or a week, then you're going into detox. I'm not sold on the idea, but we're here because we know, and I think we put value in you guys and want to see if this is something we should be doing and where is the right site for it. My sense tells me that that Southampton Street corridor, Mass Ave, Melena Cass, it's just totally overwhelmed now. So I don't see how putting, or even the talk of putting anything else there would be helpful to us. Again, I'm not gonna like sit here and shoot the idea down right off the bat. I need to gather my information. So I thank you for your testimony. And how long have you been a user? If you're
I've been using drugs for over 12 years.
Heroin for 12 years?
Heroin and other drugs for over 12 years.
Okay. Thank you.
I think, is it time for us to respond?
Yes,
Yeah.
please.
I think there's two questions to tease apart in your remarks, Councilor
Yeah.
Baker. One is the issue of, is a SIF a good idea? And that's an important question to answer, one that you're not sure about. The other is the question of citing. I think the question of citing it is a tough one for the reasons you state. I think many people are going to have concerns about citing. But I don't think that's the first question to ask, because if we start asking the question about citing before we ask, is this a good idea, I think we're asking the questions in the wrong order. I think there are possibly creative ways that we can deal with the possible urban impacts. But I would also say that the Vancouver downtown east side neighborhood was a neighborhood, and is a neighborhood that was impacted in that very concentrated way that the Southampton corridor has been. And I think that neighborhood went through the same process of, people outside this community saying, you got to be kidding me, to B, well, this neighborhood is, a lot calmer, cleaner, more orderly, fewer people dying. The end point is when there stop being people at risk for death from opioid overdose.
No, I mean the endpoint for the user. I think that I think it might be the wrong path to make it easier for using. It's almost like I may sound insensitive, but it should be more difficult to use. I think.
Can I say
yeah.
something? Just
Sure.
as a person who's down there every day for
Yeah.
hours, it's already an injection facility. It's
Right.
just not supervised. There's no people making sure folks aren't dying. People are already injecting publicly all over the place. We all know that. So I think getting over this fact that, oh my goodness, people are going to be starting to inject in a safe place where they make sure they don't die. I really don't understand what the objection is. People are already doing this. They're dying literally every day. 6 people a day in the state. I'm confused as to why there would be any limit on keeping people alive.
So my point from the person that represents the neighborhood down there, the people that aren't injecting drugs and that live there and pay property taxes and this is their neighborhood. Like, I think there should be real thought into how some of those services are being spread out across the state.
Oh,
You
I
know,
agree.
and I don't know if putting a SIF there is going to be helpful. I just don't think it's going to be helpful.
Could
And
I
I'm
chime,
trying to be respectful also.
could I chime in? I have 2 thoughts. First, about that issue of the endpoint that you raised. I think you're asking good questions, which can help to talk about the path of addiction for folks. We know addiction as a chronic disease, similar to diabetes or other things that don't go away. And so, when I think about an endpoint, I think that it's not that this goes away ever for somebody. They need to be able to manage it as best they can. And it's sometimes in their lives, they're very vulnerable. And it's sometimes in their lives, they're not. And when it comes to addiction, that is usually during use and during recovery. But people go back and forth between those. So
And for most people, it's never going to go away.
yeah,
And when I talk
even when
about
you're in
and when I-
recovery.
let me just
Yeah.
tell a
Oh,
quick
sorry.
story here when I'm talking about endpoint. So now I've taken people to detoxes before, and for heroin, and that sort of the endpoint for me to bring that person was, okay, you're going to get high now. Okay, you're in the back seat of the car. You're going to get high in the back seat of the car. That's hopefully the last time you're going to do that. You're going to be with me. Then you're going to detox. That sort of endpoint. I just wrapping my mind around, okay, this is going to be 200 people in here shooting up, and it's here available. Like, there's no endpoint there. So Joe could move across the street, and then this is his life. It doesn't really seem like a life.
Yeah, and I think the way that our current situation is, and I'm going to put on a different hat as a resident here. I live on Concord in the South End. I also work in the South End, but I'm a resident there, and I have been for many years. And I take my laundry to the laundromat, and I walk through an alleyway, and I see people injecting in my alleyway. I find needles there. I call the mayor's hotline. Little plug for the mayor's hotline. But it's frustrating to see that where I live. Not just because I care about these people, but also for me. I mean, I don't want to step on something. This is this is a problem in our community now, and people are using. So I think that the difference that a SIF offers us in the South End or anywhere where this is an intense issue is really to take that use off the street and engage people when they're not. We're not engaging them now. Not like that.
I think
So.
that might be the one positive that I could take from this is you're definitely going to see less paraphernalia and less, happening in that area. But the chances of someone not copping right outside the door of the place, say they're copping in my neighborhood in Dorchester, they're not going from my neighborhood down to wherever. They're going as soon as you can get that needle in your arm. So, I again. How is this not? How does that not bring the demon down there? How does that not bring people just swirling around the whole? How does that happen?
My thought on that, I think heroin is sort of everywhere. You don't have to go very far to get it.
Right.
And so at least in other cities that have done this, like Vancouver, but also Sydney and other parts of the world, the areas that are affected are really the 500 meters around the SIF. And people aren't really traveling long distances to use one of these things. It's really the immediately surrounding community benefits the most from a SIF being there. So
I think Dr. Dorkin had maybe a response, then we'll move on. Thank you.
Thank you. Number one, it is a chronic disease. And there are many people, for instance, with alcoholism, and we don't really cure it, but they come off of it and they stay off of it. But they know that if they take another drink, there's a very good chance they may get into trouble again. So we can't expect that we're going to cure this perhaps any better than we can cure alcoholism. What we can do is help people get off of it and stay off of it and be aware of their tendency to it. Number two, if we look at the slide that I showed about the Commonwealth of Massachusetts, it clearly is not just in the city of Boston. There are other areas in the Commonwealth that have just as big a problem, and where the pilot project should be, we wouldn't presume to suggest where that should be and would defer that to publicly elected officials and departments of public health to figure out where this would best be used first. And I think that the third thing is that the people in Vancouver around the area where the SIFs are were very vocal in their feeling initially that they didn't like the idea. And then after they saw the results, they came out in favor of it. And not just passively, but were actively saying, yes, this should be refunded because it's made a tremendous difference. And I think that those people probably have similar concerns to those that you've expressed. And I would expect that, I would hope certainly that the responses would be the same.
Thank you.
Thank you, Dr. Dorkin. Councilor McCarthy.
Thank you very much, Madam Chair, and thank you for the entire panel. I feel an awful lot like Councilor Baker here. You know, the human stories are very compelling. The data regarding saving lives, you know, fantastic. Data leading into recovery, tremendous. But as somebody who spent his entire career trying to make Boston neighborhoods better, I really have a question. Because you're painting downtown east side of Vancouver as if it's like Beacon Hill or Wellesley or Duxbury. Now, maybe I'm watching the wrong documentaries, but that's not the neighborhood that I'm seeing. I've seen a lot of documentaries, and I've been watching them. I've been doing a lot of reading. You gave me more. You killed a lot of paper today, a lot of trees dead today. I'm very concerned with what I see in downtown east side Vancouver. Not the painting of the picture that you're painting of this neighborhood. Everybody's saying, oh, this is the most wonderful town in the world. It's not. And from the comments that I've seen on some of the documentaries, people are happy that it's there, not for the reason why you're saying. They're happy that it's there because it's contained within a 500 meters around, just like you said, Doctor. People in other neighborhoods are happy that it's there. So everybody who is an addict or who needs help, they go to one section of the city and they leave their city alone. So this is very concerning to me. And it's not even my district, but I used to work in public works and we were down in Frontage Road. You know, we were right next to the clinic. I know what goes on down there, and it's not a pretty picture. So I'm going to continue to do my research. I have a lot of reading to do, but I encourage people, and I said at the last hearing when we announced this hearing, is that there are documentaries out there specifically about Insight and that area and that neighborhood. And that neighborhood is a disaster. It's not this beautiful painting that you're drawing for us. It's not. The street next to it is called Blood Alley. I mean, you know, this is not a nice place. So let's not paint this picture of, oh, everybody's wonderful and everybody, you know, this is the greatest neighborhood ever. The second piece that we haven't really talked about is the cost. Who pays for this? Who runs it? How much taxpayers' money is going into it? And why does Boston always have to shoulder the burden for the entire state? We're the economic engine for the entire state. And every time something like this comes around, everybody looks at Boston. I guarantee you, I can name 10 suburbs right now that would never, ever be considered. And Doctor, with all due respect, I know you live in the city, that's great. When you posted that, you know, 132 to 27 vote or whatever that was, I'd love to know how many people in that vote were from Boston and how many people would love to have this across the street from their house. Because I can tell you right now, I don't want it across the street from my house. I'm not a big NIMBY guy. I've fought hard for a lot of different things. But this isn't something I'd want to put on burden of taxpayers who own homes, who own condos, who own businesses. This is a very tough pill to swallow for somebody who lives in that 500 meters that you're talking about. So I'm going to continue. I'll read all of this, I promise. I'll continue to do my research. But, you know, I'm not, nothing that you've said today makes me say, oh, geez, I'm going to change my mind.
Just to respond briefly to your comments about neighborhoods, I certainly wouldn't paint the East Side as some kind of tourist paradise. That's for sure. I think the response of the folks there was that it was making a very bad situation somewhat better. And I guess I would also, I think obviously every counselor is going to feel a deep responsibility, not just to the people of the city, but to the physical fact of the city and the way this affects it. So I hear that. I do think I would urge you to consider first thinking, does it make sense to try to make the epidemic safer in this particular way, and then say, is there anywhere to do that? And because, and the reason I respectfully suggest that is, if you go right to citing, the conversation in your mind is going to stop. The public health value of it is sort of over because you're already having the second part of the conversation in your head. As I said, I completely understand why you're having that part of the conversation, but I do hope that you'll consider the public health part of the question, how do we get people to survive another day so that they can make another try at recovery? And this is why we tell this particular young man's story. It was just so heartbreaking to us, and this has happened again and again, where people are really trying, but 100% success on a try at stopping using is pretty tough, and a lot of folks do not stop using, and their deaths, their illnesses, their hospitalizations, all of that makes a big impact on the city. So I would start there and then ask, is there a place to do it?
May I address the second question?
Yep.
The second was about cost. Cost effectiveness was dealt with in our report. Just last week, Johns Hopkins University supplemented our data with new estimates. At an annual cost of $1.8 million, a single SIF would generate $7.8 million in savings, preventing 3.7 HIV infections, 21 hepatitis C infections, 374 days in the hospital for skin and soft tissue infections, 5.9 overdose deaths, 108 overdose-related ambulance calls, 78 emergency room visits, and 27 hospitalizations, while bringing 121 additional people into treatment. San Francisco researchers found that a 13-booth SIF could save that city $3.5 million annually. So the savings from the collateral damage would be very significant in terms of the outlay.
So I read that little blurb in your presentation, and that's why I mentioned the cost savings in my opening statement. But you mentioned collateral damage. What's the collateral damage on a neighborhood when maybe businesses shut down, people start moving out? What's that collateral damage? I mean, that's where we have to. And I understand your job is to promote the health, and I get that. My job is to protect the city. So I want to make sure that whatever neighborhood this goes into, if it goes into a neighborhood at all, it's fair to say that the people who live in that area should have a say. That's all.
Can I make one point really quickly? The Vancouver SIF is an 8-seat facility, correct?
16.
16-seat facility. They are, I think part of the problem with the reason why there's so much high-intensity public drug use is because that's nowhere near enough for the number of people who are using drugs on the street of Vancouver. I think there's an unsanctioned SIF that's opened up outside. There are other ones that are opening up the next year, and I think that's going to reduce the amount of public injection that's still happening in the area and the public drug use.
So in the last documentary, and this is my last point, Madam Chair, is that there is now a program that they are providing heroin up there. Is that our next step now? Is that when is this? There's a great concern with that, right? Because I'm pretty sure that when they started their SIF, they never thought they'd take that next step. But there is now, I was watching a documentary, I'll look it up if you need to know for the record, but now there is a gentleman who runs, and they are providing heroin now. That scares me. As somebody who has 2 young boys, this scares me. We are going down a dangerous path. Thank you, Madam Chair.
Thank you, Councilor McCarthy. We're going to just swap Councilor Zachem for Flaherty for a brief moment. Thank you.
Thank you, Madam Chair. And I want to thank Councilor Flaherty. I have a meeting that starts right now, so I appreciate him accommodating me. I have just one question. I think it's probably for you, Director from the Public Health Commission. One, what's the commission's position on this? And is this even allowed? I mean, I know there's a bill at the State House, but are there federal permissions that are required? This strikes me as something that this body, even if we all were in agreement, couldn't authorize on our own.
Thank you for that question. So I think there are others on this panel that can talk about the legal. I think that was part of the Mass Medical Society's study, but from what I understand, the reason why we don't have any SIFs in the United States at this point in time is because they are illegal, because of federal and state laws. In terms of our position at the commission, I think our position is the same as the mayor's, which is these are illegal. And what we focused our efforts on as a city and as a health department really is on the continuum of services that Devin and I have walked through. I will say that I'm in a learning mode, like many of the counselors, and trying to get up to speed and hearing what some of our clinicians on the panel have shared in terms of what they've learned in their environmental scan of what's happening in Vancouver and in other places.
Thank you. I just say I want to thank you both for bringing this forward, but I think it can be an emotional issue, a fraud issue. It's obviously complex, and I appreciate all the experts and people who are telling us about it, and whether this is successful. I'm certainly very much someone who wants to look at the numbers and the data and do things that can make everyone in our community safer. But I think before we are all expending a lot of resources and time on this, I think we need to know what is even feasible. I think certainly this current federal administration is not one that I would expect to be giving any sort of exemptions. I mean, they're talking about coming after medical marijuana now, which we've had in this state already for some time. So that's, I guess, my quick and dirty view on this, but I appreciate everyone's time and your testimony, and I apologize that I have to go to another meeting now.
I think
Thank you.
Dr. Dorkin had something to maybe add to that.
Just two comments. Comment number one, clearly any task force that looks into this in great detail would have to look at any legality issues, whether they're federal or state, and we would assume that would be part of what the task force would do. The second, I just want to make a comment that at no time has anyone in the medical society even hinted at the concept of providing illegal drugs, ever.
Thank you.
Thank you, and thank you, Counselor. Counselor McCarthy.
Councilor
sorry,
Flaherty, thank
Flaherty.
you. Thank you,
Sorry.
Madam Chair. So obviously I'll preface my comments in terms of being from a recovery family, having been the longest serving city council here. I would argue that no one has done more on the city council around the issue of treatment and recovery than me. So I'm sensitive to recovery. I'm sensitive to treatment options. Spend a significant amount of my time as a city councilor working with individuals, working with families, trying to find them detox, treatment, recovery. Stood with them and the families in court, having them sectioned. I happen to subscribe to treatment on demand, and if that doesn't work, court-mandated treatment, I think, is also better options than what we're discussing. And I preface that because anyone that says that if you're against this, that you're inhumane or you're not sensitive to treatment and recovery, I would also probably look through the gallery here. I would argue that no one has probably lost more loved ones, more neighbors, and close friends to addiction than me and my family. So that said, I think this idea is asinine, absolutely asinine. And Doctor, you had mentioned sort of from the public health side of things, but that's not how it plays out in the street. And I come at it also as a former assistant district attorney. How it plays out in the street is the average heroin addict does about a gram of heroin a day. That's somewhere in the vicinity. It could be 24, 25 glassine bags a day. And if we think for 1 minute someone's going to buy or score some heroin and then take a train or a bus to get to this facility, that's not the reality. It's they're going to inject or snort within minutes of the purchase. And they do that because they need to keep that high going, or they're afraid they're going to get rolled, robbed, or it's stolen from them. So that's another exigent circumstance. Or they're afraid they're going to be stopped by the police and have it seized. So this vision that we have of people scoring heroin and then taking the taxi ride or the bus ride or the long walk, similar to what we see sort of as we call methadone mile where everyone sort of congregates at the Dunkin' Donuts at Andrew Square, and then they take the long pilgrimage over Southampton Street Bridge to get their fix. That's not going to happen, Doctor. That's not going to happen. So unless the whole drug trade is going to go to surround itself, it's going to be wrapped around this particular facility. The reality is that when someone scores heroin, they're not waiting. They're not waiting. They're going to inject or they're going to snort, and it's going to be within minutes of that purchase. So unless the buyers and the sellers are going to be moved closer to this facility. So that's just that. Doctor, you just mentioned something about, make no mistake that, medical professionals are not going to be supplying this, but they're going to be in the presence of a Category 1 substance. And I'm not quite sure how that works sort of ethically from, professional medical standards, but putting doctors and nurses and other medical professionals in the vicinity where there's a Scheduled 1 substance. I don't think that's currently allowed. You can correct me if I'm wrong, but I don't think it's, so yeah, you're not supplying it, but you're in the presence of it. And I think that's wrought also with some legal and ethical issues. I think we're going to start to normalize it for the next generation. I think it sends the message that controlled, the use of controlled substances, or in this particular, the use of heroin is acceptable. And also, I think it's going to push the limits of high, so that when someone normally will take a certain amount, and hope they come through, they may now push the limits of their own boundaries because they think we're going to be there with the paddles or we're going to be there with the Narcan. And again, I just think this is wrought with many issues, and I would rather have us having a discussion about more money for treatment and recovery, treatment on demand in the city of Boston, and where that doesn't work, court-mandated treatment. That's where we have our best results with respect to that. So, and finally, Doctor, where do you live? What community do you live in?
I live in Newton.
You live in Newton. So would you think this would be great across the street from your house?
If that's where the state felt it was the most advantageous to help the people of the Commonwealth, yes.
Well, Newton's a city.
I grew up in Baltimore,
Right.
and I grew up across the street from the Johns Hopkins Hospital originally. And let me tell you, that's a dangerous neighborhood down there.
Right.
And I would have had no problem with it there. And if it happened in Newton and it was felt that that was it, I'm still a physician, and I want to see what's best for our patients.
Right.
So I would accept the decision of the Commonwealth as to where they felt it was best cited.
As referenced earlier, there's no neighborhood is immune from opioids. I mean, it's affecting our whole state. So will you join? I'll go with you if you want to go to sit with the mayor of Newton and the Newton City Council and propose putting this close to your home.
Well, if that's what the Department of Public Health comes up with in the Commonwealth, that's where it ought to go, yes, I'll go with you.
Well, where have they come up with a location as
Well,
of date?
they haven't formed the task force yet, sir. That's
So
what
there's-
we're requesting.
So I'll just, very quickly, there is a second bill up at the State House regarding a feasibility study to look at locations.
Okay. And what is the mechanism by which we're going to be testing, say someone comes in with a glassine bag, we're calling it a Schedule 1 substance. Are we testing it for fentanyl? So it could be heroin, or it could be a lethal dose of a combination of different things, and we're just going to sit and watch and wait to see what happens?
Again, you anticipate things that I can't predict at this point in time, but would want to wait and see what the task force came up with.
So we're going to have a facility that we're not going to be able to test the substances that people are bringing in through the front doors. We're going to watch them inject, snort, whatever, and we're going to sit by and wait to see whether we got to jump in and render assistance. I think that is absolutely asinine. Appreciate your time and attention. Thank you.
Can I respond, please, Counselor?
Quickly, yes, because then we'll
Regarding-
move on to Council Jackson.
Regarding fentanyl, there is no heroin left in Boston. There's none. Everything in Boston is fentanyl or a fentanyl analog. There is no heroin left in the city. There probably isn't any heroin left in the state. People having access to a GCMS or an infrared scanner to be able to know what they're consuming in a supervised injection facility would be incredible. So people know what they're consuming, they're able to use safer, and the people who are supervising them are able to have a heads up as to what the person is going to be, the result is going to be after the use.
So the option, through the chair, the option is recovery, right? And I'm happy to help you. I'm happy to help anyone that you think could use the help to get clean and sober. And I think that should be the end game here. It shouldn't be providing safe houses and normalizing the activity. It should be trying to get folks off of heroin and now in this instance away from deadly fentanyl. That should be the goal here. It should be a shared goal of everyone in the chamber and beyond. but I don't think it should be putting sort of safe injection houses within the confines of the city of Boston.
Thank
So
you,
I'm all for
Council-
treatment and recovery.
Thank you, Councilor Flaherty. Councilor Jackson.
Madam Chair, and thank you, Councilor Baker, for bringing this to the body. As someone who grew up in Roxbury, I have to first go to history, and I want us to think about how we treated people who were on crack in this city of Boston, in that same neighborhood, and how we failed them. How we didn't do any, at that time, it was three strikes rules, RICO cases, mandatory sentencing, lock them up and throw away the key. That's what we did in our city of Boston, in the state of Massachusetts, in the United States of America, to folks who had the same issues around addiction. But their faces were different. They lived in different neighborhoods. And so I just want to just take a pause, and ironically, today is Juneteenth, the day that the last slaves in Galveston, Texas, actually found out that they were free. So this is an irony right now that we are having this conversation today, where 20 years ago, 30 years ago, we were having a very different conversation in the faces. And had we treated those families and those residents with dignity, respect, and the advocacy that they need and that we see right here today, many lives would have been saved. Millions of dollars in the failed war on drugs would have been saved in our Commonwealth in the United States of America. And we would actually know a whole lot more about addiction and what needs to happen. Mm-hmm. And so I'm a little heavy-hearted on this issue right now because I grew up in the same neighborhood. And there are people in that neighborhood who went through a whole lot, in particular in Orchard Gardens, which was called Orchard Park back in the day. And so I just think we need to be mindful of what is going on in our city. And I think a couple other issues that we should be thinking about is the responsibility of the city of Boston in exacerbating the issues that have happened in that area by closing the Long Island Bridge and pushing people out of detox. Actually, first off, condemning a bridge and then putting people on top of that same bridge after it was condemned. Pushing people out of detox, and people died. And that blood is on the hands of the Boston Public Health Commission, the city of Boston, and it happened on our watch. And that has exacerbated the situation there. In addition, that is further conflated with the closure of the city's own methadone clinic. And where did those patients go? Interestingly, those patients were relocated to a facility closer to this area. So I don't know Vancouver. I've never been to Vancouver, but I definitely daggone know what happens on Melnia Cass and on Mass Ave. And I know the city of Boston is complicit in exacerbating the situations that have happened in that area, regardless of whether we have a SIF or not. It happened on our watch, and people died. And people are dying because of the actions of the city of Boston, and a tent ain't gonna fix it. And so, as we have this conversation, what I know is the state of Massachusetts has failed the city of Boston in permitting methadone clinic after methadone clinic after methadone clinic in the same area. And so I don't have a lot of trust in the state of Massachusetts on these matters and these issues. Do I think that people need help? And do I see a very strong human face to this? I don't want to hear, and I went to a neighborhood association, there were 14 overdoses last summer in a half a block area. That's happening on our watch, and we got to fix that. And I want to hear more stuff about how we deal with these issues. That's very real. And I appreciate that physicians are stepping up. on these matters, and I need to self-disclose that I did pharmaceutical sales in that first slide. Right? I sold a product called Cadian. It was an extended release morphine. Nobody wanted it. They didn't want it because they wanted OxyContin when I was doing sales back in the day, and it's only gotten worse. So what I need to know is that people who live in these neighborhoods and in these communities, folks who do business and risk their own capital in those neighborhoods and communities are going to be on this board. Because what I do know is the McDonald's, it's a great gentleman that used to own that. He sold it. The gas station, very nice person used to own that. They sold it. So there has to be a community voice at the table on these issues, because time after time after time, the state of Massachusetts has failed the city of Boston on these issues, with a hyper concentration of methadone clinics in that area. And I guess I would also just note, I hear you on the deferred cost. Every single time somebody ODs in that area, the police, ambulance, and fire are all called. And I would love to hear through the chair the numbers relative to those calls and the cost associated from our fire department, police department, as well as ambulances. I think that's a critical component. And I think we need to look at that as savings in the future. But I also know that there is a disproportionate amount of burden that is felt by a specific small part of the city of Boston. Now, we got to listen to folks who live in those neighborhoods, who are having their doors kicked in on a regular basis, who are dealing with, sadly, issues. And I had someone who had a door broken, who had something stolen that was exponentially less valuable than that door. So we also have to look at it from a quality of life perspective for those folks. And there could be a compelling case there. But I just know that it is absolutely critical that something is done. But I know as a local elected official that the state of Massachusetts has not served us well. And I would ask, and through the chair to the doctor, that you demand that there is local representation from folks who live in that neighborhood, live in that community, do business in that community on that board. Because that is the highest concentration of distribution of methadone, I believe, in the state. If someone can show me someplace else, then that would be fine. Again, I thank you for this. I think we have to be thoughtful. We have to look at the data around these issues, and we have to be thinking about how we save folks' lives. I would also note, if we're not having a conversation about detox beds on demand, then we're not having a real conversation. If we're not having a conversation about increasing the needle distribution in the city of Boston, we're not having a real conversation. I see the folks back there, but there's not enough of them. They work their butts off every single day. And if we're not having a real conversation and listening to the people who are on the ground, then we are actually doing ourselves a disservice and wasting folks' time. I want to thank the two co-sponsors of this. This is the issue of our time in the United States of America post World War II. We're going up every single year in life expectancy. Last year's numbers, we saw for the first time in a long time, we actually saw life expectancy in the United States go down. And I deal with a district from Back Bay to Roxbury that has a 33-year difference in life expectancy. My wish and hope for the city of Boston is that that we move towards the 91.9 in Back Bay versus the 58.9 that is the life expectancy in Roxbury currently. That is actually lower than that of the life expectancy in Gambia and lower than that of the life expectancy in Iraq. So I'm all ears and thinking about things that we can do, but it has to be measured, thoughtful, and inclusive of people in our neighborhoods and communities, and also the businesses in those neighborhoods. Thank you so much.
Thank you, Counselor. I would have just two quick responses to your remarks. One, this council has changed, and it's part of why we're here, especially in regards to our relationship with the state. This is why we're here, because it's so important for us to have this conversation, because it does so directly impact the city of Boston, and both positively and negatively. So I have a couple of quick questions. In Vancouver, if any of you could speak to any changes in the number of individuals using heroin for the first time. I don't know if any of the data has shown that, because with the small number of beds, a high number of visits, I'm just wondering if we've stemmed the tide of new users, or does the number continue to increase? I'm not sure if you've got any of that data.
I haven't seen those data expressed in that manner, but obviously it's something that we would like to know.
And then regarding the SIVs, who operates them typically? Is it a Department of Health or equivalent? Is it a government agency, or is it a private entity? Because one of our challenges, especially with some of the methadone clinics in the city of Boston, is that they are privately operated, and that presents certain challenges for sure. I don't know if anyone knows who operates SIVs.
I think in the 11 nations around the world that have this as a model, and about 100 plus different SIFs, there's a lot of different models. So many of them are run by governments locally or otherwise, and some of them are relatively private, nonprofits, et cetera. I think that this is probably something that a task force, if constructed, would definitely look at.
Right. And then I'd like to recognize that we've been joined by my at-large colleague, Councilor Ayanna Presley. I know that you've had just a moment to come in, but it's...
I'm just listening. Thank you.
Any opening comment or...
No, not
Very
at this
good.
time. Thank you.
So my colleagues... Yep, so if my colleagues have any additional follow-ups, I'm all set, but I'll go with Councilor Baker. And then we'll prepare after the second round for our second panel to come down.
Thank you all for your time. Joe, you made one point a couple times, and you kept coming back to it, and I just, I appreciate it. Like, it's, so we have to, as the city, have to have a full discussion. So when we move forward, or if it moves forward, and where it moves forward, citing is after a full discussion. So I think what Councilor Sabi and myself are looking for is to have this discussion, so we all know what to expect, and so we can advocate properly there. But I like the way you said a couple different times, let's get our facts and see where we are with it as a city, and then we figure out the site. So, and again, not to bring it back, but my issue is, since I've represented this area down there's been a couple things that were just kind of, they happened, and there was no discussion on them. And one of them, Councilor Jackson talked about the second methadone clinic that happened on Bradson Street there. So we really need to be in the discussions, and let's bring the whole state in also. Thank you for your time.
Thank you.
Councilor McCarthy or Councilor Flaherty?
The doctor, if through the chair, if in your circle and the discussions you're having, if you could let the folks know that they should be looking at other locations outside of Boston. I'm preparing to think about a possible text amendment to the zoning code to ban them. So I would like to see a wide and broad-based suggestion of other areas, other locales, preferably the suburbs, because no one does more around treatment and recovery than the city of Boston, but it would be great for suburban communities to step up to the plate because they're not immune from treatment and recovery issues. They're not immune from opioid and heroin addiction. In fact, when you tour the facilities that I've toured, most of the men and women that are in those treatment and recovery folks in halfway houses and three-quarter houses, they're not from the neighborhoods of Boston. So when we're looking for a place for our own children to recover outside of the neighborhood, outside of the area where they've been buying and selling, there's no beds available. So I would ask you in your circles if you could push back a little bit, or at least open up the discussion that there's some resistance in Boston and that they ought to look at some other locales and bring those destinations and locations to the table as well. Thank you, Doctor. Thank you, Madam Chair.
Based of the Commonwealth, and we would not presume at the Medical Society alone to make a suggestion where it should be, but would assume that the state and local governments would put their thoughts together and come up with the most optimal location for such, and that it would move forward from there. We're not going into this with any preconceived notion of where it should be.
Thank you, Dr. Dorkin.
Thank you.
All right, so we'll get ready for our second panel. I thank you all for joining us today and for your very thoughtful presentation and thorough presentation today. Thank you.
Thank you.
A brief applause while we're swapping out panels. So next we'll have Dr. Robert Baratz, Allison Burns, and Brianne Fitzgerald. I'm out. Brian. 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 Dr. Baratz. Nice to meet you. Thank you.
Councilor Baker, I'm up there.
So it appears that we have adjourned or recessed. We have not. And thank you all very much. And I welcome you to the City Hall chamber. I think we're getting some slideshows or some presentations set up. And I think we'll start with Dr. Baratz.
Thank you, Madam Chairman.
If we're waiting, you can just give a moment. That's okay. Thank
Can we
you.
go to full screen?
Yep.
Once again, thank you very much. I'd like to say who I am and why I'm here first, and to thank all the media for leaving.
Here.
Well, and all of those who have interest for staying. I'm a primary care physician in this incarnation in my life, but I've also been a professor at medical school for close to 5 decades at a number of medical schools across the country, and more recently here in Boston for the last 40 years. I see patients every day. I have patients from every stripe and fashion of work, communities and stuff in my practice, and we take all insurances. I don't speak here for Boston University or Tufts University. Those are my academic affiliations. I don't speak for Beth Israel Deaconess Hospital, Milton, where I'm on staff, or Kearney, where I've been on staff for a long time, or many other places where I'm affiliated with. I hope to bring some information here that hasn't been said so far, to give some perspective to the counselors in their deliberations about this very important issue. And I guess, I don't know how this one works, but if I start pushing buttons and get the wrong one, I think forward might be to the right. Yes. There we go. Figured it out. I'm going to go through these rather quickly because I want to put the notion of addiction in perspective, because we've been talking mostly about drugs and injectables, and I think people forget there are other types of addictions, and they should not be neglected in how we handle public health issues, because they're equally important. So because injected materials have a greater risk, that's why we're all here today, to talk about safety. Obviously, the consequences of addictions are known to many of us personally and through others that we're associated with. And I'm not going to read slides because I think all of you know how to read. But basically, they have a major impact on society and the workplace and multiple other people and parties, our families, our friends, our neighbors. Society demands that our representatives do something because we have a bit of a crisis going on. I don't want to spend this time talking about how we got here, although its history is very important. I did know George de Santillana when I was at MIT, and history has a way of repeating itself if you forget it. He said that. So we need help from all the stakeholders. Many are here, some are not. We want to look for solutions, and we want to engage everybody in trying to get something by focusing on what happens. I look upon myself as a guy who solves problems every day. I get up, I go to the office, and people come in with their problems. I have to forget mine. So I say, okay, what you got and what can we do about it to make you better or your life better or something else better? So that's problem solving, which most doctors do, and my colleagues who were here before do the same in their own ways and in their own places. Now, we may not all agree all the time, but that is our goal, and we're pretty much dedicated to the health and welfare of our patients, sometimes at our own peril. Now, treatment of addictions varies. It depends on the type of addiction in terms of substances. As has already been said, relapse is common. Compounds which are highly addictive, that is in a physical, biological, physiologic way, are much more difficult to deal with because they almost change the brain and demand that they get that again. Withdrawal is a significant problem, so merely detoxing someone is not necessarily going to work. I've had plenty of patients who've gone through detox and plenty of patients who've retoxed. Injectable substances of abuse now include some of the things that have been mentioned. I'm also a medical review officer, and I review drug tests for employers, Coast Guard, the Navy, and many other places to see whether people have drugs on board when they apply for a job or whether they're found in a random search. That includes truck drivers and thousands of other people. So it was said before, I just want to make a comment that heroin and other things like fentanyl are not necessarily coming together. That's not 100% true. I think we see what we see because we're in a particular environment, but some of us see different environments. So strategies for treatment, I think, are familiar to most people: withdrawal and reprogramming if possible, substitution of agents that are of more controllable medical consequence, such as methadone, buprenorphine, which is mixed with another substance called naltrexone, and it becomes Suboxone, and naloxone pills, and now heroin, as is done in England and some other places, as a treatment rather than as a street drug. In other words, pure heroin of known quantities that can be used instead of street drugs. What the main issue with these SIPs is harm reduction, and I'll call it the lesser of two evils. I mean, is it better to have someone injecting in the alleyways and doorsteps, or is it better to have someone injecting in a facility where help might be closer? And I'm going to dwell on some of that because a lot has been said about the conditions in Vancouver, and I think not all the data fit what has been said. There have been changes, and I don't think they've been brought out here. A safe injection facility makes sense if you have no other alternatives and you're trying to look for some form of safety, but it comes at a price. And those prices have been illustrated by Councilor Baker, and I don't know all the names of all the people who spoke, so I don't mean to pick on you or highlight you in any particular way. But safety is the principal issue about what this seems to be all about. But it's not just the safety of the person, it's the safety of the neighborhood, it's the safety of the community, it's the safety of a lot of other things, including the medical staff. So let's look at this recently published graph showing deaths in overdose in British Columbia. The whole province, not just Vancouver, but obviously Vancouver and Lethbridge and Chilliwack are some of the bigger places there. I've been through all these places earlier in my life. So you'll see that the number of deaths
where this facility has been in place for 20 plus years, have started to climb in the sort of the changeover into the teens, the 2010, 2011. And the data that was last published were not quite these, but this is what's going on now. And this is as of 2015. So these are a year plus out of date. Now, years ago, I went down to Walter Reed to get when the HIV epidemic was in its infancy, and sat and listened to a very intelligent speaker named Dr. Redfield, who was talking about epidemics. And when you see that something takes off from the horizontal to the vertical, then you know you really have a problem. And the real question is not that, Houston, we have a problem. The problem is, what is the problem? And I will tell you in advance, the bottom line here is not the fact that people are injecting drugs. It's the fact that fentanyl is now so common. It's all over the place, even in small towns in New England, in the Midwest, and everywhere else. We can talk about why that happens, but the reality of it is it's so easy to transport, you can put it in an envelope and mail it. And because the post office is not in the business of opening mail like that, it goes all over the country with great rapidity. And the real problem we have is not safe injection facilities. It's the fact that if we create one and people are coming in with lots of fentanyl, there's going to be people who die there. And I'll show you why. So the current version of heroin, pure heroin, not the brown stuff. I worked in an emergency room for 10 years, so I've seen all this stuff in every shade of gray. But fentanyl is a manufactured synthetic drug as opposed to heroin, which is derived from poppies. And the question is, where do all those poppies come from? And the answer is Afghanistan. And we've been fighting a war there for a long time to stop that. But apparently we haven't been very successful. All right, so carfentanil is a more potent version of fentanyl. So taking these by themselves, if you accept that heroin has the same potency as morphine, they're both from the same plant, and call that one, then the potency of fentanyl is about 100 times more. So if you took 100 milligrams of heroin, 1 milligram of fentanyl, which is about the size of a speck of salt, would be the equivalent amount of 100 milligrams of heroin. But carfentanil is 100 times more potent than that. So the difference between carfentanil, which is pretty easy to get and is now finding its way to the streets here, is 10,000 times more potent than the heroin itself. Now, for comparison, OxyContin has a morphine equivalent of 1.5. So it's only 1.5 times what you see in the heroin bottle. And that's whether it's OxyContin, oxycodone, or any of its derivatives. Okay, I don't think you can read these very well from in the back of the room. And these data and those pictures came from Canadian television and the Post and Mail, which is the Globe and Mail, which is a large paper in Toronto that does very good reporting. And you can find this stuff on the web, and that's where I got it all. These charts show the change in years by each group of bar graphs there of different provinces as time went on in terms of deaths. And what's important to look at is the black and red. And the black one is British Columbia, and the red one is the eastern provinces, which are more populated. I think the next one over is Alberta. And why Alberta? Because there's so many drugs there because of all the oil money. Now, this is a pill-making machine, and anybody can buy one of these and have it shipped in from somewhere. And why would you want a pill-making machine? Well, because you can take very small amounts of fentanyl, mix them up with a little lactose and other binders, and end up with pills. So now you have money, how to make money with fentanyl. 1 kilogram, 2.2 pounds of fentanyl will, when divided up into pills, with small numbers of milligrams in each one, Its cost to the purchaser, $12,000. Its value after this, $20 million. And this is the problem. These drugs are so potent and so plentiful and so easy to get around and so deadly that we need to work on the sources more than what happens to the people who take them, I'm afraid to say. Because without that, we are shoveling against the tide. On the right here, you'll see there's two little packets like those things that come in your electronics that keep things dry. This was a bottle of urine dipsticks, and those little packages inside are not so innocent because those were used to smuggle heroin into the country. And because they're less than 30 grams each, which is the weight of a shot glass of whiskey or water, cc equals 1 gram, so 30 grams. These are far less than that. The amount of fentanyl in those little packages there is $10,000 each. And you take a little bit of that, and you get a pill machine, and you throw together some ingredients that you use for making pills, a little lactose, and if you're lactose intolerant, I guess you need another substance. But put all this together, pop it in that machine, and they call these greenies, and these sell on the street for $20. And that's part of where that $20 million comes from. It's $20 a pill for these things on the street. And it only takes 2 pounds of fentanyl to make $20 million and 20 million pills. This is a safe injection facility. We've talked about what they look like. So what are the benefits and risks of a SIF? Well, the first is there's some benefit, obviously, for 20 years of experience. They have contained the number of deaths. There are more people that are getting into other treatment programs and all of that. But Canada is a different country. Financing healthcare there is different. There are some differences to us. They're not huge, but they're worth talking about and not the subject of what I want to talk about today. So can the Canadian approach work here? And the problem is the data that have been presented, that it's done so well and only 30, certain number of percent have been saved, are all changing because I showed you that graph. Well, suddenly the whole province of BC has exactly the same problem we have here in Boston. Last year in this state, 85% of the deaths from opiate overdose involved fentanyl, plus heroin, plus other drugs. It's mixed with cocaine and several other things. And that's where the real problem is. Now, are SIFs got risk? Yeah, they're expensive to operate. I mean, the number that was given out at the Medical Society was $3.5 million for this site. How many hundreds of people are going to use that site? I mean, you're going to concentrate people in an area where you may not want them being concentrated. Forget about NIMBY, not in my backyard, but think about walking into methadone clinics. You can see people exchanging drugs on the outside. I mean, I have patients who are on methadone, and they tell me exactly what happens, and I've seen it for myself. So putting things together doesn't always make a problem better. There are these other problems that we've talked about, but until these problems are solved, I wouldn't be in favor of having something like this, but I think they could be solved with very thoughtful design and structure and a systems design. For example, you don't know what's being injected. That's already been talked about, but the technology is so simple that you could have a mass spectrometer sitting at the door and actually tell them exactly of how much of each thing is there. The companies who do drug testing, by the millions in this country, do it on millions of samples a day. Quest, MedTox, LabCorp, and a number of other ones in the Midwest. They go out in the office in a bag and they come back the next morning all analyzed. So it can be done. It's not like it's rocket science. It's not. These are illegal drugs, as has been said. So it would be impossible to do this at all unless there was some kind of a waiver, permission, or whatever from the federal government. So that's a big issue. Now that creates other problems because suppose you're a doctor and you're supervising a clinic like this and your malpractice carrier says, oh, sorry, you're not covered anymore because you're doing something that involves illegal substances. Same can apply to the other staff there. So more likely than not, as long as people walk in the door with whatever they want to bring, you're going to have fatalities because someone may have the most potent carfentanil in the world, and I'll show you how potent that can be. And if they inject that, I don't care how much Narcan you have in your hands or in your closet, you're not going to be able to act fast enough. And suppose 10 people come in at the same time and do all the same thing, and there's only 3 people on the overnight shift and it's 3 a.m., it doesn't compute. So enough protections have to be built into these things to think of the things that we don't always think of. You know, I've had the experience of having to run 3 codes by myself in the middle of a night in an emergency room, and you want to talk about sheer terror. That's it. So is there a better way than doing this than just using SIPs? And the answer is probably yes. I think let's take a look at how easy it is for fentanyl to get in, though. This is a small fentanyl lab in China. These pictures were done by an undercover investigator and published in the Canadian papers. But this is a big one. And, you know, you only need 2.2 pounds to make $20 million. I mean, that's better than the lottery. So here's what 2 milligrams of powder will look like next to a penny. And this is enough not just to put down a horse, but this is carfentanil that would put down an elephant. Now, if this got into a human being, you might as well have picked out the casket before you do
2
it.
milligrams would put down an elephant?
Yes. Carfentanil. It's 10,000 times more potent than. So this is just a list of papers on using heroin, like they do in England, as a substance for treat abuse. You get the heroin, but you get pure heroin, and you can inject it in a safe facility, and doctors can write prescriptions for it. That's an alternative to walking in off the street with whatever you want. So why should we change this? I think we have a problem in that we definitely have many drugs. We have definitely many people who are addicted, and addiction is a horrible problem for anyone who has it, or their relatives, or their counselors, or everything else. It's not going to be solved easily. But if you're going to have safe injection facilities, we need to make them safe. They have to be so safe that they will be foolproof. And until that happens, I'm going to stand up and just say, not so fast. And let's think about it deeply, because we're really fighting that curve now, and not just getting people to be able to be supervised in a place. That era is over. And the next generation of drugs that are coming after carfentanil are all synthetic, and they are all more potent. Because our society seems to want more, incredibly more, and incredibly more than that of everything. And that's the problem. Example, a lot of people may disagree with me, but marijuana, which is on the medical marijuana that is in use today, has a content of THC, which is the hallucinogen, tetrahydrocannabinol, that is on the order of 10 times more potent than it was in the 60s. 10 times more potent. There's nothing medical about that. Tetrahydrocannabinol does not give any medical properties to marijuana, but the plants have been bred to do that. Why? Because people want more of a buzz, a higher high, and all of that. The actual medicinal drugs in marijuana have not been thoroughly studied. There are some very preliminary studies that show some of them have benefit for very particular conditions. But the whole story about medical marijuana, in my opinion, is a bit of a subterfuge. And, you know, I'll say it here in public and in front of the TV and everything else, because that's the truth. And anyway, I thank you for having me today. And I'm sorry if I took more than 7 minutes, but I hope I've educated you a little bit on where the risks are and what you need to look at before you consider these issues. Thank you very much.
Thank you very much. Brian,
Thank you. Thank you all for having me.
if you would just move the microphone just two in front of you. Thank you.
So my name is Brianne Fitzgerald, and I'm a nurse practitioner and have been in the nursing field for 40 years. I think all of us in this room, on both sides of the table, medical colleagues and nursing colleagues and outreach workers are doing the best we can do to try to reach this population that tears apart families and communities. And I do want to acknowledge that I'm also speaking on behalf of the Metro Boston Alive program, which is in Roxbury. Gregory Davis is the founder and executive director, and he wanted me to speak on his behalf also. My opposition to safe injection sites come from over 35 years in the field, including being part of the original harm reduction vanguard in Boston during another crisis, the AIDS epidemic. During those early years, the idea of harm reduction was to meet the person where they were at and support that part of them that wanted to live. This is what the injection drug use group did. We went out to the suffering addict. Prevention education through the provision of bleach, followed by clean needles and syringes, was done by addicts in recovery in the communities most impacted by HIV. The medical establishment had nothing to do with this original impact in the community. The recovering addicts, the people that had some recovery and sobriety under their belts, collaborated with the Boston Municipal and Roxbury courts to provide AIDS education and expand treatment on recovery. Once again, the larger recovering community decreased the AIDS seroprevalence rate from 38% to 14% among injection drug users in the city of Boston back in the late 80s and early 90s by the bottom-up approach, not the top-down approach. The success of these early days of harm reduction were born from the human need to share the experience, strength, and hope, and to help others navigate the human experience and let them know that wellness can take place in the absence of a cure. That's what we said about AIDS back in the day, and that is still true with substance abuse. Wellness and recovery can take place in the absence of a cure. Today, the idea of harm reduction has been significantly altered. Today, we invite the addict to come to us to access clean needles, although they are available in pharmacies, to come to us and ride out their high. And now the Mass Medical Society is providing its stamp of approval to invite drug users to come into our site and shoot up and perhaps die with help. The idea of projecting any desires or hopes for the client that we are serving to consider a healthier lifestyle has been eliminated. Suggestions are not offered. Misguided idea that the addict will ask us for help when they have had enough. Drug use has been normalized in this city. I see the safe injection site as a hospice care for end-stage addiction. We have given up hope on the person walking into a safe injection site with a bag of drugs that they will consume under our watchful eye. As been noted before, who can know what's in that glassine envelope? And what if they do die on our watch? Who will pay for that? And as speaking as a nurse, I can stake my reputation that it will be the nurses sitting with the patients and not the doctors. It is enabling a behavior, injecting or snorting drugs of unknown quantity and quality, that has no possible good outcome. As the National Institute on Drug Abuse has said, the brain has been hijacked by drugs. Will we then allow this brain dysregulation to go on uninterrupted and unchallenged through the paternalistic efforts of a safe injection site? Why go to treatment when you have all the things necessary to get high right here on methadone mile? Why are we not creating more opportunities to get sober rather than more opportunities to get high? It is our role as healthcare providers to help the population address their struggles and trauma, and to offer ways to explore and challenge their anxieties and avoidance. Or have we become part of the problem? We have thrown our hands up and said in so many words, giving you a place to inject, during business hours, of course, is the best we can offer right now. We can do better to help people. The Hippocratic Oath at first blush is remembered for the words, do no harm. But the original quote from the Book of Epidemics by Hippocrates reads, as to disease, make a habit of two things, to help or to at least do no harm. The proposed location at the corner of Mass Avenue and Albany Street is ground zero for dirty needles, 2 methadone clinics, an isolated industrial neighborhood, 2 shelters, a big city hospital, a 10-story mental health facility, a health center that caters to the homeless. Street action includes beggars harassing cars as they head to the interstate, a bustling needle exchange program that already provides quality overdose care to those who are on site, people sleeping on cardboard in plain sight of daily foot and car traffic. Homeless people who say they would rather take their chances in the bushes over the drug-infested and violence-fueled shelters. New arrivals to Massachusetts from all over the country congregate near the Department of Transitional Assistance, as they have heard the benefits are comprehensive and easy to access. Drug deals going on in broad daylight, and the sign only recently taken down at the Bubbles car wash said, flashing "Welcome to Amsterdam." McDonald's just recently closed their sit-down restaurant as drug deals and overdoses were so commonplace there that the security guard, whose name I will not reveal, told me that the EMS got tired of showing up there several times a day. If you have a loved one addicted to heroin, would you want them walking anywhere near the Methadone Mile area? And if you're unfamiliar with this area, then I welcome you to join me on an ethnographic tour some morning. We can do better by offering services that are life-affirming, hope-giving, and realistic. I'm actually willing to entertain alternatives that may impact the current opiate crisis. The idea of a mobile van, which in and of itself will eliminate the NIMBY issues, can be a symbol of the crisis, and the van can be situated once a week in multiple areas where overdose rates are high, not just in Methadone Mile. There are Brockton, Hyannis, New Bedford, Framingham, Springfield. The Department of Public Health needs to pay attention to this. On this van, yes, you might actually have a little area to inject safely under the watchful eye, and there will be the usual harm reduction supplies and opportunities to test for HIV and Hep C. Recovery interventions, however, will be part of the team. Volunteers from Learn to Cope will be available to family members, recovering people who will also volunteer, much as they did in the early days of AIDS. Access to the medication-assisted therapy, or opiate replacement therapy, as I like to call it, will also be available. The symbolism of the van is that it will represent that this opiate crisis is more than the addict. It's the family, the community, and all must be educated and alerted. Perhaps politicians from the communities outside of Boston visited by the van will also show up to field questions. Maybe the local Dunkin' Donuts will provide us some refreshments. This issue is a public health issue that needs interventions on multiple levels. Consider putting methadone and buprenorphine in pharmacies and then allow patients to go to the pharmacy of their choice daily or weekly to access their medication, and therefore dilute the mass of sick and suffering people at the clinics and the drug dealers that prey on them. Now, here is an intervention to put your voice to, Department of Public Health. My personal belief is that if we stop treating the addicted person like a sick animal who doesn't know any better, if we keep telling them that they have no control over their stopping, then they don't and they never will. Let us raise the bar from the end-of-life care to the hard work but invaluable experience of wellness by addressing the deeper mental, emotional, and spiritual causes of this disorder. Thank you.
Thank you, Brian. Allison Burns.
I have slides as well.
Oh, very good. I think Nadine will set them up for you. And while she's doing that, if you would just introduce yourself for the record, please.
But thank you, first of all, for having this conversation. I think it's very important for us to have an open dialogue with both sides of the table being present. My name is Allison Burns. I'm a registered pharmacist. I have a Doctor of Pharmacy degree. I have 2 academic appointments at 2 Boston universities where I teach addiction medicine and substance use disorder. I'm also the director of 2 pilot programs that have to do with increasing Narcan in our community, including mobile dispensing. I'm the founder of a nonprofit that deals with getting pharmacies more involved with the substance use community, because why not get drug experts involved with drug addicts? I'm also an advisor and a member of a task force for a government agency, and I haven't named any of the facilities that I work with, so everyone knows that this is my independent testimony and not affiliated with any specific institution. That all being said, I think more importantly, I'm a Boston resident. I lived in Dorchester for a while, and now I live in Southie. I'm also a U.S. Navy veteran who was injured and was on opioids for years through the VA. And I'm also the sister of an addict who's not in recovery. Okay, so the number one thing that we have heard in support of the supervised injection facilities have been that they save lives. It reduces mortality. So what does that really mean? We're reducing the drug overdoses, whether non-fatal or the actual fatal overdoses. And yes, I'm not going to disagree with the opposition. SIFs do save lives. They do reduce overdose deaths. but it's in the facilities. And that's what is the key point here. So the statistic that you got about Vancouver in 2011 with 35% reduction in overdose deaths, I want everybody to be very clear. It was 35% within 500 meters of the facility. All of Vancouver combined, it was 9%. I'm not going to cherry pick statistics to make my point sound better. This study also was conducted 2 years pre and post opening, so it was only January 2001 to September 2003, and then to December 2005, but yet it was published and researched all the way up to 2011, and it failed to include the full set of data because it wasn't as favorable as the 35%. And yes, the doctor before was correct. There has never been one single death with people using the supervised facility. Using, keyword. I would encourage everyone to look out and see how many people who used the SIF died outside the SIF. Going ahead, there are other facilities. So there's a SIF in Sydney. Their own committee, put by the people that run that facility, found that there was no evidence that that facility affected the number of overdose deaths in the King Cross area where it is. Moving on, the European Monitoring Center, 2004 review of drug consumption rooms, that's what they call it there. They looked at the number of overdose fatalities averted for all 25 SIFs in Germany. And for every 500,000 injections, there was 10 averted overdose fatalities. And that looks great. And I'm very happy that there was 10 fatalities that were averted. But averted fatalities, we have to be very clear and very precise when we look at the language of these studies. That does not mean individual lives saved. I'm a pharmacist. I have people that come in that overdose, and because the half-life of Narcan is not that of fentanyl, they go into recurrent respiratory depression. They can have multiple overdoses within a single day. So 10 averted overdose fatalities could be not 10 people. The data is an inaccurate portrayal of the target population based on that. A more clinically appropriate denominator is averted fatalities per visits. So this would even include people that, say, go to the facility, overdose, go out, and then come back in, overdose again. It would actually include that as two separate instances. It would count it as, it would count twice, as opposed to being counted more times than that when it's in one single visit. So it really doesn't also account for the frequency of drug use among the cohort. So what I mean by that is, if I was to do heroin today, I would probably only be able to, shoot up once. But, for example, my family member, my brother, 6-7 times a day. We can't be considered equal in that. The frequency has to be taken into account because the average number of injections, you're saying 500,000. If I'm doing 10 injections a day, that's much different than, I might just look at that and think, 500,000 people, each doing one. So really, it's much less than what you think. Moving on, it's just a complete lack of comparative framework and baseline data. So we really have to have an accurate portrayal of the target population, the entire city, so all of Vancouver, that 9%, and then the variations in drug use. So it should be more likely to be visits and not injections. So therefore, we can't really conclude that there is a causal relationship between the SIFs and a prevention of overdoses that is superior or more efficacious than the other harm reduction modalities that we're currently using. So, for example, increased access to Narcan, increased access to medication-assisted treatment, all the other harm reduction strategies that we know, that we've studied here in the United States and we know work. Cost effectiveness, so this is a big point. When we're looking at this, we're really evaluating the estimated costs versus the cost of what would be avoided if the IV drug user associated harms such as infectious disease, societal burdens, access to treatment, all of that. My main point here is the majority of the literature that is out there. So the statistics you heard before from the doctor that was here previous that were San Diego. San Diego doesn't have a SIF. No place in America has a SIF. Those were researchers in a think tank. It's all hypothetical. It's mathematical models. I like to base data on real things. I was in the pilot program in the Navy. If I did my data based on hypothetically what I thought I was going to do, people would have died. You can't do that. These are people's lives. It's important that we get it right so we can do it right the first time. So based on mathematical modeling, it's not actual data. And why do we keep going to Vancouver? So if you look at SIFs, they've been around since the 1980s in Europe. Why are we not looking at the 75 other active ones in the world? And why aren't we looking at the ones in Switzerland that shut down? Just something to bring up. In the interest of time, I won't go into why we're not looking into those. It's just a question I want to raise. So moving on with the cost effectiveness, supporters say that it improves, that it improves the incidence of infectious disease. So what are we talking about here? When you're given safe injection supplies, there's going to be less transmission of HIV, Hep C, Hep B. Yes, of course, anytime you get clean supplies, there's going to be a decreased transmission. But all that being said, the actual data for this is very mediocre at best. So when you look at what Vancouver said, now this is 2005, the Canadian Centre on Substance Abuse, so equivalent to what our BSAS would be. They said there's no firm conclusion that can yet be reached regarding the impact of CIFs in relation to the spread of infectious disease. There wasn't a proper comparison. There was no studies that actually compared ID outcomes of the CIF to ID outcomes to current addiction treatment or harm reduction programs such as needle exchange. In the United States, we use empirically based data. So one of our most current and effective ways we found to prevent HIV and Hep C and Hep B, any type of needle-borne or blood-borne transmission of disease in the IV drug user populations, we've seen the success of MAT, and we've seen the success of education, and we've seen the success of other harm reduction programs. We also say that supporters will say that it improves health and it reduces risky behavior. So what do I mean by that? So decreased use of the unsanitary equipment, so clean needles, decreased sharing of needles because they actually have access to the needles, and the decreased hurried injections, which would cause some type of soft skin tissue infection. So when you actually look at this data, it's also mediocre. And what I mean by that is, so if you can see up there, Vancouver had a questionnaire that was given 6 months and 13 months after opening. And it showed that even though they were offered to get free needles, clean needles every single time, self-reported in the facility, 16.5% still shared needles. Because there's a lack of education there, not a lack of access to the clean equipment. That's an important thing to note. Sydney, same thing. Surveys were given to a cohort of randomly sampled CIF users in 2000, 2001, 2002, and the results showed that using new needles did happen. I won't ever say that there wasn't support for that, of course. It was 64%, 75%, and 79%. That's great. However, at the same time, the actual education and culture around needle sharing did not change. 19% in 2000, 16% in 2001, and 18% in 2002. So even though they had access to these materials, it did not change the behavior. We need to look at behavior modification. That's just another important topic I wanted to bring up. So when we look overall at risky behavior, the results of the study are primarily based also on these self-questionnaires, people coming into the CIF and you're giving them a questionnaire. And that's great because you're getting in contact with the actual user. However, are these reliable results? When are these given? Are they given before injection? Are these people, what is the actual judgment and mental status level of the respondents? Because I think it's very important to have addicts at the table. I think they should have a seat at the table because they're the ones that are using the facility. They're the ones that have the most to benefit from this facility. So I want to hear their opinion. I don't want to hear their opinion after they shot up, and I don't want to hear their opinion when they're high. I want to hear their actual opinion. So there was never any baseline mental status studies done that showed when these questionnaires were given. Were they given before or after? Or were they given even to people that there's a lot of dual diagnosis, so untreated mental illness and other conditions, or their emotional state. The self-questionnaires are important, but they have to be administered at the correct time. So because there's an absence of comparative data here, it does not really compare that the respondent baseline needle sharing to CIF needle sharing. So you would need that. I have no problem with saying that, yes, it's access to clean needles, absolutely, but until you have a comparator there saying that, okay, the CIF had these many clean needles and this was the sharing there versus a harm reduction such as the needle sharing programs we already have in that area in Boston, and seeing how the needle sharing happened there, give them the same questionnaire and compare it. Don't base it on mathematical modeling. Don't make a statement that you can't back up with real data. And I'm sure if you look in Vancouver, they do have needle sharing programs. So if we're going to keep going back to Canada, then let's ask them to compare their needle sharing program and their SIF and look at that data and compare that as a comparison. So when we're looking at access to services, so this is a big component of this. A lot of the support has said this is an increased access and gateway to social services and addiction treatment. But the measure of outcome that they use for this, for increased access to services, is the number of referrals given. This is a very, very, very weak indicator of success, and I'll tell you why. It's an inaccurate portrayal of clinical significance. So there's a difference, especially in pharmacy and medicine. We have statistical significance, and we have clinical significance. You can be statistically a significant number, but if it is not clinically significant, then it is not cost effective and it does not reach your target population. So be very careful again when looking at these studies. It wasn't of clinical significance. Most of the studies have been based on the assumption that the referral given leads to the uptake of treatment or partial completion of treatment or even completion of treatment. Now, I know because I work in residential treatment facilities, completion is very hard. Relapse happens all the time. So I'll even throw that out the window and say, let's just follow up and see if that person was given a referral, did they get into treatment? Not even if they finished it, not even if they partially finished it. I'm talking an interview at the place. That's all I'm asking for, and there's no data for that. The referrals are a starting point. It's erroneous to call these an ending point. It is not an endpoint. It can't be used that way to compare data. Referrals provide information regarding the potential service uptake, the potential to get into a social service or MAT program, but it says nothing about actual uptake. A more appropriate way to look at this, because of course if I'm going to criticize their data, I want to offer something that they could use in comparison. So what they could do is the actual number of referrals, and then beyond that, the actual uptake from those. So the actual uptake in treatment per referral. It would be a much, much, much better comparison. So if we look at that, we actually look at the data. Oh, I think this died.
You do it, Nadine, just on the laptop.
Well, if we look at the data, I'll start with Vancouver in 2015. I tried to bring the most current statistics I could find in support of this. Okay, sorry about that. Okay, so in Vancouver in 2015, they had over 200,000 visits. So you look at that, 263,713 visits by 6,532 unique individuals. And I think that's great. I'm not going to deny that's great. And then 5,368 referrals were given. 464 referrals to detox, which actually translates to 6%. So it's important to look at these numbers as they are. And 262 actually completed treatment, so that's 2%. So 98% of the people in there that got referrals didn't finish treatment. Again, addiction is a relapsing chronic condition. I don't expect them to finish treatment, but I would hope that they get in it and get that opportunity to be well. The referrals to detox, again, of the 100% that are going in there, only 6% are even getting a referral to detox. So it does not account for also the individuals that received multiple referrals. So if I go in there, and I say I want to go to detox, and after that I want to go to a residential facility, and I also want services because I'm homeless, and I also want to get employment opportunities. That's like 4 different referrals, right, for one person. So again, it's not an accurate portrayal of what's really going on. So a better way to look at it is I actually did find some data where it broke it down to the referrals per individual. So if you don't have those results, though, and all you have is number of visits. Now remember, somebody can come in multiple times, so I'm even giving them that. And you actually look at the 5,368 referrals that were given out among the 206, over 2,000 visits. You see that it's actually only 2%. It's only 2% are getting referrals. Visits. So I'm saying even in the visit, you can get as many referrals. I'm even giving them that. If you actually look at March 2004 to April 2005, you see, again, over 200,000 visits by 4,764 unique individuals with 2,171 referrals given. They actually did follow up on this one, and they saw that there was 804 individuals that actually received those referrals. So 16% of the people actually received the referral. They had no data on how many were actually got into treatment or actually used those referrals. So in Massachusetts, to put in context, we're always talking about the limited number of beds and the limited ability to get into treatment. So say we do open one of these, and we do actually are much better than Canada. We do it right, and we make sure everyone works out with a referral. Where are they going? Where are they going? We can't give referrals to everyone, right? There's not enough beds, there's not enough treatment. Where are they going? We're going to put them out in the street? I don't know where they're going. It's just something to bring up. Another thing is we're all concentrating on these SIFs. They target and reach the most at-risk population. So we're talking, again, that corner of Melnia, Cass, and Mass Ave. My actual clinical site, my primary site, is right there. So I'm very familiar with that area. But what we need to look at, so I'm going to give the actual data as it is. There is support that does prove this. So if we're looking in Germany, in Frankfurt and Zurich, we're seeing that actual SIF users, they use it 5 times per week, and that's good. That's great. I'm glad that they're getting off the street and they're using it in a safe environment. In Rotterdam, they're using it an average of 6 days per week. Okay, that's good. That's Germany. Let's expand it now, because remember, every place is a little different. Let's go to Sydney and Madrid. Over the periods of 18 and 26 months, clients averaged fewer than 2 visits per month. Clients in that area that we're targeting. 2%. I don't understand. They knew that it was there, so what is that component? Why aren't they using it? Then we look at Vancouver, and it showed that only 45% of this is their own statistics that they provided, that their government provided, 45% of the sample of active IV drug users reported ever using it. Ever. They went around, they handed out surveys, they asked, did you ever use it? And of those, the majority, the 57%, used the facility fewer than a quarter of the time for their injections. So that scares me, that they're still using it on the street when they have this option. So what I would say is the data really is very inconclusive. So if you're going to do basic utilization statistics, you have to be able to definitively show that the target population has been reached, and it really hasn't been done yet in these studies. We need a more detailed and accurate picture of the overall drug use, such as the findings in terms of the proportionality of usage and what else is going on in that area. So if we look at actual heroin use in Vancouver, so if we look at before the SIF and after the SIF, you can see there wasn't that much of a difference. So we're looking at, now we're not looking at 96, we're looking at 2001. So if you compare 2001 to 2011, so the SIF from when it opened 2011, we're looking at a couple percent. Didn't really alter the heroin use. I didn't put in here, because I didn't think it would be brought up, the issue of crack. That actually went through the roof. When the SIF, I can show you that data later, crack went up, and there was more fatalities from that. So pretty much when we're thinking about this overall data, just the applicability. The study results really should be interpreted, I think, with the knowledge that, yes, they give us some background, and it's important. It starts the conversation. It's important to look at this data, but they don't necessarily reflect or apply to every city around the world in the same manner. So really, there are great differences and variances in drug culture in terms of just the culture, the economics, racial differences, drug availability. So even in the United States, if you look at the Southwest versus the Northeast, you're going to see meth in the South, you're going to see opioids and heroin in the Northeast. It's just completely different. And the United States as a whole, we got to think about our culture. We consume 80% of the world's opioids, and we are 5% of the world's population. How are we going to scale these international studies to that our level of usage, because we're up there. We did bring up the looming legal issues, so I'll just briefly touch on this. So opposition.
Alice, if you don't mind, just how many more slides do you have? Because I want to make sure my colleagues have an opportunity for question before testimony.
So a lot of people say in the opposition, so in that camp, that the government really shouldn't facilitate or enable this type of model, pretty much. We shouldn't enable drug using or SIFs, and I think that's more of an opinion than a factual statement, so I want to make that clear. The reality is that there will be a significant legal wrangle to make these sustainable. The SIF, if placed in Boston, would have to obtain an exemption from the Title 21 United States Code of Controlled Substances Act, which dates back to the 1970s. Also, mind you, exemptions are not permanent, they're not lifelong. So for example, in Vancouver, their exemption from their actual law was only for 3 years. And then you get into the question of what happens after the 3 years, or say we get it for 2 years, 5 years, 10 years. The government says we're not going to extend it. What do we do with the facility? What happens to it? And do we challenge it in the Supreme Court? What happened? Do we shut it down? What happens with changing administrations? There's so many questions there. Do we really want to invest time and money in an option that might be shut down? I would rather spend it on an option I know will stay open to help these people. They need help, and it needs to be sustainable. Finally, in the situation we are right now with the federal government, the federal prosecutors have already said, they've already made the statement that the United States must maintain control over drugs policy, and SIFs fragment the rules of our nation. And federal authorities, just to bring it back to a couple other things, if we say, oh, they're not going to actually act on this, I have no opinion on medical marijuana. I just want to make that clear. No opinion. But if we're looking at that, they've raided and shut down medical marijuana dispensaries that were legal within their own states, in Colorado, California, and Washington. So what's going to say, are they not going to come in here and shut down this? Because if it's working, I don't want it to be shut down. It's something to think about. And just remember, when we're talking about if the feds can go in there, we are Massachusetts. So it's very important to remember this, because I understand this in pharmacy. I think this is something that's not brought up a lot. As soon as that drug crosses state lines, it is now federal law. So remember, we're not giving them the heroin. So if I have somebody from Rhode Island, because Rhode Island doesn't have a SIF, and they buy heroin in Rhode Island, and they drive up to Boston, and they go in that SIF, the federal government can come in and cross state lines. We're a small state. We're not Texas. You know, it doesn't take long to get from New Hampshire, Vermont. That scares me. That scares me for the user and the people in there. What's going to happen when they come in? So all this being said, this is the end. Thank you for your time. So I also want to ask about funding, because where is this funding going to come from? And if this funding is going to decrease the funding we're already using for that pool of substance use and addiction treatment, if it's going to take away from that and that local outreach, I would almost say that's a social injustice to the people that use it. What about our brothers and sisters on the Vineyard and the Cape? We're going to take money from those programs. We have to be very clear about where the funding's coming from, first of all, and where do we go from here? Say we need to go up from here. I know people talked about actually providing heroin. Are we going to decriminalize drugs in the United States anytime soon? Probably not. Again, we're going to get into a legal wrangle there. It's a very, very complex problem. So I really think that this is more of a stopgap than a solution. I would caution against having a SIF without, comprehensive longitudinal studies and an actual mitigation. Look at the harm mitigation programs they're using. So I would support something like SPOT. We have SPOT right here in Boston. It's a supportive place for observation and treatment. It offers almost the same exact benefits of the SIF. The only difference is you can't inject in the facility. After you inject, you go into the facility. I believe there's 8 chairs. I'm not sure how many. You go in there under the watchful eye of a nurse or a medical member there, whoever is manning it. You get reversed. You get supplemental oxygen, you get referrals into treatment, you get clean needles, you get all of those benefits at SPOT.
Thank you.
And SPOT's
Allison.
working.
Thank
so
you
we
very
should probably
much.
look at that.
And thank you to this panel. I'm going to open it up to a question for my colleagues. Councilor Baker.
Thank you. Dr. Bob, you said something and briefly, how did we get here? How did we get here? Not for, like, how did this epidemic explode on us, your opinion?
Well, I went to all the drug summits that were held at the Medical Society with all the state and federal people and listened to all the experts. We got there because we have not been mindful of how narcotics are misused. And they were freely available on the street. $20 a milligram, so to speak, for your grandmother's OxyContin that you got from her medicine cabinet from her broken hip. And
When did the oxys hit the scene?
Well, quite a while
You know
back.
that, Brian?
1992.
92. And can you, Brian, can you talk a bit about replacement therapy and like where we are? Because I think you made a statement earlier, like maybe we might be going about this the whole way. Wrong the entire way. And I think the replacement therapy is, I see value in it, but I see kids getting off heroin and getting on methadone for the rest of their life. Where is the end on that? Can you talk about that a little bit?
That is a question about, I mean, I'm all for replacement therapy with a beginning, a middle, and an end.
Right.
But there is no. And the National Institute on Drug Abuse just joined forces with Big Pharma to find new ways to cure addiction, new medical ways. I think the medicalization of addiction treatment is part of the method.
Yeah, part of the problem.
It's a-
problem. No end. Exactly what you said there. There's no end with the methadone, and I see that as a problem.
It's important to look at these drugs as different entities because people don't get high with methadone, and they rarely get high with Suboxone. But
I have to interrupt. That is
Yeah,
completely
because
incorrect
I talk
from
to
a
people
pharmacy
that are on
point of
Suboxone,
view.
they sound like they're drunk.
I have to disagree with that. For somebody, I have 150 patients. I take care of all their medications. Over 50% are on medication-assisted treatment. So I completely support that. But actually, you can get high on Suboxone. Buprenorphine is the longest-acting opioid we have, which is why you use it, because it breaks that reward cycle. The only thing that makes it non-abusable is the naloxone in there. And why? Because when you shoot naloxone, you go into withdrawal. So actually, if you take it and you haven't used opioids, then you're just getting a long-acting opioid. So I have guys in my facilities that actually started with things like Suboxone and pills like that. You can actually buy Suboxone with heroin right now. You just go outside Methadone Mile, you can hear them saying subs.
And
That's
it's
what they're
traded in
talking
the
about.
prisons too, the Suboxone is. Dr. Bob, do we?
Counselor Baker, I didn't completely answer your question before, and I think that the problem is that our society tends to self-medicate, and that's where a lot of addictions come from. Whether it's cigarettes, which make you feel more comfortable because nicotine's a relaxant, or whether it's alcohol, which is a depressant. So when you're anxious, you take that, but then you get hooked on these things physically, and that's when the problems really come in. So I think we're talking about the same thing in a different way, and I don't think we necessarily disagree. But I have many chronic pain patients in my practice. I have a large occupational disabled population in my practice, and methadone is a great drug for chronic pain because maybe 5 milligrams will take care of half a day, and it's a 12-hour drug. But those who are intent to get a better experience, if I can say it that way, don't want that. They say, oh, I'm allergic to it, or it doesn't work for me, and all of these things. But they want OxyContin or oxycodone because it produces a high. And I think it's the addicts who want the height are a problem, because once you've experienced that, whether it's from cocaine or oxycodone or injectable fentanyl or something like that, nothing else will satisfy you. And there's some studies that show the brains of some of these people have actually been changed by these drugs to the point where they can't live without it almost. So it's, addiction of these things is extremely difficult thing to treat and to manage.
I'm not going to be. We could talk all night. Like certain things, your first experience with detox is a 3 or a 5 day. You're setting people up for failure. There's no way someone can come in on heroin in 5 days, get it out of their system. I mean, we should, as a state, we should be talking about 30-day detox. That's it. There's nothing under 30 days, and we shouldn't. I mean, those are the types of discussions we should be having here. It's a huge, huge problem. And I mean, you brought up some interesting points about methadone in pharmacies. That would kind of end some stigma there. There wouldn't be 2,000 people down on the Southampton Street corridor. So very interesting points. And you talked about, so in England they replace, so their replacement therapy is heroin.
It's one of their replacement therapies, but it's not street heroin. It's pure heroin that's been refined and is
synthetic
actually,
or
you could have it either way. I mean, the molecules are the same, but you don't have to worry about the purity of this or whether there's anything else going on with it.
It's not going to kill you.
And they're under strict control. Doctors can prescribe that to addicts to keep them stable. Those of us who practice primary care, let's say, are not licensed to treat addiction in our practice unless we get a special certificate. So I can't prescribe methadone to my patients for substance abuse treatment. I can prescribe it for chronic pain, which is what it's best for. But the clinics that prescribe methadone put people on hundreds of milligrams a day,
Yeah.
whereas at the pain treatment levels, something in the order of less than 30 is probably all you need. And those equivalencies.
So where are those discussions happening? Like what? Like who makes the calls? Like to you know, I'm newly out of detox. All right, let's put him on 30 milligrams of methadone for the rest of his life, or 70 milligrams. Like how are we making, Brian? How are we making those decisions?
The Department of Public Health encourages people to go on Suboxone or methadone. That's the treatment. Actually, the detoxes now are turning
Brian, will you
into-
just move your microphone, please?
The detoxes are turning into medication-assisted therapy
Yeah.
induction centers.
It feels like business to me.
It is.
That's what it looks like.
It is. That's why I can't say who I work for, because I
Yeah,
won't be
that's o-
working for
that's o-
them anymore.
That's okay. That's okay. And there was one other point that I wanted to make. Thank you.
We can come back to you. Councilor McCarthy.
Thank all three of you, and thank Madam Chair for hanging in there. Really, thank you all for your information. Allison, thank you for your service. Certainly, thank you for statistics, because as a baseball fan, stats always run through my head. And my dad always used to say, there was an old saying, I'm probably going to butcher it, and if he's watching, I'll probably hear it later on. But he always used to say, he uses statistics like a tired man, as support instead of illumination.
Statistics
and
are powerful but dangerous sometimes.
Yeah, you know, and I kind of, as you were going through those stats and breaking down, that really seems to be what these data points are being used of, support, not illumination. And I appreciate, I certainly know you're going to, those will have the copy of her testimony. I certainly want to go through those because as I create my own thoughts regarding this, and as I said in my opening statement, I don't think this is a good idea. I never have. But the statistic that you have thrown out there in your 10, slides or however many there were simply tremendous. And I appreciate all of the time and effort that you put in to that, again, to illuminate this hearing. Thanks.
Councilor Flaherty.
McCarthy, obviously, this was a very impressive panel. Doctor, I'll note, you said society is it's a self-medicating society. I also will add that doctors and dentists also overprescribe. Had a friend of mine that just went for a tooth extraction, and he got prescribed 40 oxys. That person was derelict in their responsibility. Of course, he refused and said, no, I'm just going to go old school. I'm going to use Tylenol.
I agree with you completely.
Gotcha. I also had a loved one that just had, major knee surgery, and after the anesthesia, and we had asked for a block, and then after that, it's been Tylenol and Motrin. She's been an absolute champ, in some pain, but nonetheless realizes and recognizes that a significant number of our addicts, it all started with a doctor or a dentist appointment or a surgery. So kudos to her for weathering the storm, but that's what we need to be doing, I think, more often is weathering the storm through pain and pain management. So, and also just wanted to footnote, Allison, I've served here as the longest serving city councilor. I have to say that you've been probably one of the more impressive individuals who've given testimony here. You were very personal, very thoughtful, very thorough, very compassionate, and also very factual. I think you completely discredited the first panel. I was questioning sort of the bogus stats that they were presenting from Vancouver, British Columbia, and others, but I have to say that from my perspective, that was an enormous help to me. I'm sure it's an enormous help to my colleagues. I'm going to make sure that my colleagues who weren't here get a copy of this testimony, the time and effort that you and Brianne and the doctor put into coming here and taking this matter as serious as you did. It's very appreciative. And also as a footnote, thank you for your service to our country as well.
Thank you.
So, thank you, Madam Chair.
Thank you. Councilor Presley.
Add my voice to the chorus and just thank you for lending your expertise and your point of view. Really appreciate your comprehensive testimony, and again, what you're doing in the community every day. I would say it's, I don't know, I guess it's just the times we're in that it seems that debates can very quickly boiled down to a very hard line of demarcation of us versus them. And, you know, the point of our hearing from all stakeholders and all those who stand to be impacted for any issue, because I don't think it's our job as elected officials and policymakers to do what any one group tells us to do. I think we're elected to exercise our best judgment, and we can only do that when we're fully informed. And so I welcome and appreciate all the voices and all the perspectives that have been offered here today. And certainly as someone, I do want to give a shout out, you know, to my dad, as we often do in these discussions. My father battled a heroin addiction for almost 20 years and was only able to get sober while incarcerated, which is the story for so many. And very proud of him. And, you know, he's now gone on to attain 2 advanced degrees. He's a professor of journalism and a published author. And we almost missed out on all that brilliance. So he's 28 years sober. So, you know, knock on wood, but just thank you.
Thank you, Councilor Presley, and then Councilor Baker.
Just one quick statement to wrap in. It seems like with the proliferation and the way this looks like business to me, doesn't look like anybody's getting sober, or anybody's, like we call it, recovery road down there. It doesn't look like anybody's recovering, but it's more and more, we need this replacement therapy, we need this replacement therapy. I think we should be looking at it totally different, Council Presley's father is a miracle. I always believe that anybody on heroin, it's so difficult to get off. If you get off it, you're a miracle. And I just think prolonging it with the methadone and everything else, I just think, but I don't discount the value in it for helping you to get off. But like what you said, the most important thing here today is there's no end to that. We're going to get you off methadone, we're going to get you off heroin, and then put you on methadone for your life. I just don't, I don't see how it's really that different.
Take another whole afternoon to discuss that.
Exactly, replacement therapy, and I just think we should be re-examining the whole thing. Like Councilor Presley, my father got sober 50-something years ago on alcohol. How would it be different if when he put the drink down, like he was hitting cough syrup or mouthwash? How is it different? It doesn't seem that different. I know that may not be a great, you know, like parallel story analogy, but that's the way I look at it. You know, I just think we really need to look at the way we're conducting business now. It looks like there's money here, money in big business. So thank you for the work you guys all do.
So I think we're going to wrap up in a minute. We have 2 more statements, and then we'll get into public testimony. Just so those of you that have signed up, just that's your cue to start getting ready.
Sure.
Councilor Flaherty.
Just thank you, Madam Chair, to pick up where Councilor Baker was to Brian on just the addiction issue. I mean, not going to compare heroin with crack, not going to compare any of them with alcohol, but just take a look at alcoholism, addiction. Would you ever foresee, or are there any facilities out there where someone can come in and, I guess, drink their face off, and we're just committing that they're not going to drive drunk, and we're going to watch them, and they're going to finish the whole bottle, and we're going to be there to hit them with the paddles if they don't. So, is there does that have, other than a bar? I'm talking about in a controlled environment with medical professionals, bars, nurses, medical professionals there. So someone's going to come in, an alcoholic who should be seeking recovery and trying to put their family and their life back together. Is this where we're going? If this, do you envision something like if this happens?
I would hope not. And as a nurse, I said earlier, the nurses are the ones that are going to take the fall, not the doctors, because we're the ones that are working in those sites. And if the patient comes in with a little carfentanil on his fingernails and touches my face and I'm not a drug addict, I'm gone.
Thank you.
Councilor Presley.
You know, I was taking copious notes and actively listening as well, so there may be some things I missed, and I'm going to go back and watch the video since I did arrive a little late, and I apologize for that. You know, but again, as I said, it's very challenging because these debates can very easily, for any issue that comes before our body, turn into us versus them. And as a policymaker, what I find challenging here is that there isn't an alignment of approach. And so we're getting different recommendations from the medical community, from those that are struggling with substance abuse disorders, from their family members, while at the same time, because we all want to accomplish the same end here. If you ask us if we all want to see improved outcomes in our schools, of course, but we all have different ideas about how to get there. And every single person here wants to save lives and address this scourge and this epidemic, which does not discriminate, even if, it just does not discriminate. And so could you just tell me, for those people that are looking at us and saying, I can't go to the public library with my kid, because the bathroom door is locked because it's a needle gallery. I don't want to walk on the commons because I'm afraid of what might greet me. I'm afraid. What are we supposed to? They want to know that we are engaging and employing every tool available to address this. So what should we tell those families? What's the response? What is the fix? Because there's a differing opinion of methodology here. And so even when we have to make a decision on a budget, we're debating even how those dollars should be dedicated because there's a differing opinion about methodology here. So what should we do?
Well, you have to look at the methods and see how effective they really are, because money is not infinite. And we've acted that way as a country for so long that we can spend our way out of problems and we can solve things with technology.
I definitely don't agree with that.
But it's how you apply it.
Exactly.
And doing it in a sensible way. And the only way to do that is to collect data, analyze it in a meaningful way, not just, as my colleague here said, you can lie with statistics very easily. And statistics don't matter if there's no outcome. I mean, statistics vary in the drug business so that you can get your claim in front of the FDA and you can say, well, our drug is slightly better than their drug. But from a clinical point of view, it's probably not very, very much sometimes. When you see a 10 times difference or a 10% difference, that's still something. But when you see these little small blips, it's very hard to figure out what they really are. And you just have to make huge studies to find statistical significance in that don't really pan out clinically very much. So the real question is, we're a headline society now. How many people really read the whole articles? It's like, oh, halfway through the headline, they said, blah, 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 I agree with that, boom, 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 boom. And you're not looking for the depth. And you have to look for the depth if you're going to be a policymaker. It's not just how many votes are going to come on this side or that side. You have to say, where's the real center of gravity on this issue? And where do we put the pressure to make it change? And what I was trying to say before is follow the money, which is where the drugs are coming from. And the thing that I wanted to say before when I was listening was, where does the money go that goes for the drugs? In other words, these addicts or whoever's buying drugs or giving them or whatever, they're buying them with real cash or something. Where does that money go? I mean, if you can make $20 million off 2 pounds of fentanyl, who's got that $20 million? If you follow that money, you'll find out where it's coming from and why this continues. And those things corrupt all elements of the society. You can't just smuggle in stuff with, clever ideas sometimes.
I got you, but I'm asking very pointedly, what do we tell those families? Because there is a sense of urgency. And I'm all about meaningful headway, not headlines. So you don't know me and my governance approach. So I'm not coming at this in a shallow way at all. I mean, I've done incredible work working with young parents to reduce those numbers. And there are many people that didn't want us to have condoms in the schools because they thought that was then endorsing being sexually active. And they didn't believe that it would actually be a deterrent. So those are things that were considered very polarizing and very provocative. So I'm really asking you, if you were to give me 3 points as families that are coming to us and saying, we're seeing zombie land and I'm afraid every day my kid is going to die. Are you doing everything possible to save my kid? If the answer is no, what should we be doing? What are the 3 things that we need to be doing?
Paying for good health care providers so they can take care of these people, rather than making most of us who do primary care and really are on the fire line basically work for free.
Okay, thank you.
I can give you a couple of things I think that will help. Like you said, they're scared to go to the library or the common. There should not be fear. First of all, addicts are people. We're all people. We're all in this in the human experience. And it saddens me that there's this polarizing difference.
Criminalizing.
It's just, it shouldn't be that way. So I think first and foremost, and it's free, just education, like get the word out. I mean, I know that sounds very shallow, but there's a lot of outreach facilities that can get the word out. We need to educate people about addiction, about the fact a lot of people ask me, oh, I don't understand how people went from, oxycodone to heroin. And I go, well, heroin is a pro-drug for morphine, right? And we give morphine. Like things like that, people don't even understand. So I just think it's an education point, getting education out to everybody and humanizing this. These are people with lives. They matter. And also ramping up things we know do work. We know access to Narcan works. We know it works. And it's really expensive for the new Narcan. I don't know what needs to be done there on the expense side, but I mean, I want to give my stuff out for free. I pretty much do to anybody I can, which some people might disagree with that. They think you should charge. I don't think I should ever tell somebody I'm not going to give them a tool that might save their kid's life or a loved one's life or a stranger's life.
Okay, got it.
So ramp up things for Narcan, educate, and also treatment. We need more beds, or just things around treatment and recovery. I'll expand it to that.
The same number of beds is good, it's just they need to stay longer. And they also need to have skin in the game. Our patients need to put some skin in the game. We have enabled the heck out of a lot of them by offering them spin dries. They come to detox, they leave on a Thursday because it's going to be the weekend, and then they come back on Monday. There's no wrong door. You can go to detox anytime you want. That's the short-sighted thought of DPH. No wrong door. So you just keep spinning in and out all the time.
Thank you.
I would just say there's no quick fix to drug addiction,
Thank you.
although drug addiction is a quick fix.
Exactly.
So this is
And
going to
there's
be
not an easy way.
our,
It's
before
not-
public testimony, this will be our last.
Not an easy way out of it. There's no easy recovery. What would whoever wants to answer, at what point should we be talking to our kids' education about heroin, it kills, all that, 5th grade, 6th grade, what's appropriate?
Driving your car through Molina Cass Boulevard, talk
pointing
about
it
what
out.
you're seeing.
Yeah.
It used to be when you would see somebody with no hair and nobody wanted to talk about cancer, things like that way back when. And now when you see a child goes, Mommy, Daddy, why doesn't that person have no hair? Not because they're trying to be insensitive. They're children. They just don't understand. And then the parents will explain to them, well, Johnny, they're very ill. Then, that would be actually an opportunity for parents to get involved or caretakers to get involved to see somebody that's sick on the street. Well, they're sick, and this is why they're sick.
The bad things are going to happen to you type of deterrence in medicine has been shown never to work very well because there's a disconnect between the act and the consequences. Whether it's smoking and cancer or cholesterol and heart disease or toothbrushing and tooth decay or whatever it is, those things don't work because people say, not me, not now, and they push it out of their mind. So you have to use different approaches.
Very good. Thank you very much, this panel. And you're welcome certainly to stay for public testimony. We're going to start bringing folks down. We are behind the schedule that I was going to try to keep. We do have 2 podiums for public testimony, so I'll call a handful up at a time. If you could on your own queue up on either side. And of course, as we always welcome to the City Council chamber people of different opinions and positions, I expect and certainly plan on having a respectful opportunity for public testimony. We are going to try to speed things along for public testimony. I know some of my colleagues, including Councilor Baker, do have to scoot out because we're a little bit over time, and I trust that my colleagues that do leave during public testimony will review the tape, and I'll share what's most important. So we have Stephen Fox, Pegan Doran, Ben Murphy, Kate Nathan, and Lizzie McLaughlin to start. And if you'd on your own, queue up on either side. Stephen, if you don't mind just moving the laptop, that'd be helpful. If you would, just for the record, introduce yourself and then go right into public testimony. Thank you.
First up in the lightning round, right?
There you go.
Good afternoon. I'm Steve Fox, and I'm the chair of the South End Forum. which represents the 17 independent neighborhood associations of the South End. First, I wanted to thank Councilor Sabi George and Councilor Baker in particular, not only for calling this hearing, but also for the tremendous amount of support that you have shown the South End in the creation of a now year-long working group on addiction recovery and homelessness. This is not our first time talking about this in the South End, and we have had ongoing multidisciplinary discussions about this issue, about other issues related to addiction recovery and homelessness every month. And so I want to thank you for your support on that. I also want to thank the mayor for also supporting the work on the working group, and particularly the people from the Boston Public Health Commission. They've been really terrific. I think that I have 3 points that I want to make today. The first is that the two panels sort of demonstrate the South End attitude towards the entire concept of a safe injection site or even a pilot program. And that is that we think the jury is still out. We think that there is competing research that we've done as lay people. You can do searches left, right, and sideways and can find competing views. You can find articles that say that this report of a 35% reduction is not valid because of this, that, and the other thing. So I want to be clear that we think that there needs to be significantly more research before we embrace the concept of a safe injection site anywhere in the Commonwealth. The second issue is that I think that all members of the Boston City Council are probably aware that the South End feels as though we are the epicenter for all of the addiction, recovery, and homelessness services and providers in the entire city. I don't think there's any neighborhood that has more stuff located in the South End. And what that means is that we are a welcoming community. We have tolerated all of this. I'll give you an example. We tolerated and supported when Boston Healthcare for the Homeless came to us and said, we want to start a SPOT program. That's not a safe injection site. What we want to do is we want to monitor medically some of the people that are walking in our front door, sitting down in our lobby, and then overdosing. And we need a place to deal with that as part of our primary care. And we supported that because it wasn't an outreach into the larger Boston community saying, come to the South End and get this place. It was part of primary care. Same thing with South End Community Health Center when they wanted to inaugurate Suboxone program. As long as it's part of primary care, we thought this is the right way to do it. There's going to be drug testing, there's going to be monitoring, there's going to be therapy involved. This is the way that we thought it needed to happen. So for us in the South End, I'll just make it a blanket statement. We believe that any safe injection site, or for that matter, any additional service that comes into the South End is probably inappropriate for us. We're at the breaking point. We are dying death by 1,000 cuts. And the problem is getting worse and worse every day. But all is not lost because I have a proposal to make. We've been talking in the South End and with my colleagues from Newmarket. And what we'd like to do is to propose that we have a public-private partnership. And we get the state, we get public entities, we get private entities, we get all the movers and shakers together to say that we need to create a rehabilitation campus somewhere in Boston that offers multimodal treatment opportunities together with solid continuity of services so that we aren't discharging somebody from 30 days of detox back into the Mass Cass area. And then also with residential programs and in and outpatient opportunities. I think what we think of as our mothership is something that we need to have in Boston to help coordinate all the stovepipes that are going on among all the wonderful providers who are doing such good work with addiction recovery and homelessness. Pine Street Inn is already at Lemuel Shattuck Hospital. And we think that Lemuel Shattuck, which is located in a leafy area, not abutting any particular neighborhood, would be an ideal location for us to begin to consider and begin talking to the state about. And that's what we think is going to be the solution. We need treatment on demand, we need multimodal therapy opportunities, and we need a rehabilitation campus. And we challenge the political will of everybody from the city through the state, together with all of the people who represent corporate interests in the city to begin to come to us and say, this is the right thing for us to do, this is the way for us to deal with this issue. Fair?
Thank you. And I would really appreciate it if we could keep it to 2 minutes.
Okay.
Thank you.
I'm Peggy Doran, and I'm here representing Cavalier Coach Trailways, located at 905 Mass Ave in the heart of the Newmarket area, industrial commercial neighborhood. We are the largest coach carrier in Greater Boston and are both a Department of Defense and a Department of Transportation carrier. We are opposed to the safe injection site in Newmarket for obvious reasons. This area cannot take any more, not one more service on our streets. Businesses in the Newmarket area are responsible for the distribution of about 90% of the fresh food in Boston, 90% of Boston's trash and recycling activities, and are involved in approximately 50% of the building material distribution in Boston. In addition, there are 2 major bus transportation companies located here that transport thousands of students and adults daily. As a result, more than 3,000 trucks and buses drive through this area every single day. Current conditions are already such that driving a truck or car through the Newmarket area has become a hazardous activity. The number of impaired individuals in and around the roadways has reached extreme levels and severely limits the mobility of the distribution activity of this area. Anyone who thinks this will change with the introduction of a safe injection site has not been following the police reports and news reports. In Vancouver, over the past several years, and in Vancouver, the police are working night and day to stop the drug dealing in the area around the safe injection sites. People are often not waiting in the long lines to go inside and are opting to shoot up on the street. In Vancouver, where the only North American safe injection site is located, the City Council has even gone as far as to reduce the speed limit to 18 miles per hour to protect addicts unable to tell the road from the sidewalk. We have enough trouble in Newmarket right now, and we do not want to exacerbate this.
Thank you.
Hi, my name is Kate Nathan, and I am here representing Steve Connolly Seafood Company, a Newmarket business since 1981. We are a family-owned company, and were awarded the SBA Small Business Person of the Year award for Massachusetts in 1990. And every day we distribute thousands of pounds of fresh fish across the city and around the world. We are opposed to a safe injection site in Newmarket. It will not solve the problems here and may serve to make them worse. Addicts going to safe injection sites still have to buy their own drugs, therefore they need money. As a result, we will continue to see break-ins, assaults, and aggressive panhandling in the area close to the site. A June 10th Boston Herald article titled, "Safe Drug Sites, No Recovery Road," describes the Vancouver area where the safe injection facility in sight has remained, quote, high in theft, assault, drug dealing, and a hot spot for stolen goods, end quote. Yes, there has not been a dramatic increase in crime, but there has not been a decrease either. In fact, 11 years after Insight opened, Vancouver police are still trying to get people to use the facility. On August 6, 2014, police said there were 7 suspected overdoses on that day in the city's downtown east side where the injection facility is located. The fact that the police have to ask people to use Insight demonstrates that it is not as effective as it seems. What we have found out leads us to think that the claims of success by those in favor of supervised injection facilities are not thoroughly researched. As said during the panel, the most relied upon study, the same study showing a 35% decrease in overdose-related deaths in Vancouver, published in the medical journal The Lancet, only looked at the period 2 years before and 2 years after the center opened, January 1st, 2001 to December 31st, 2005, not the ensuing decade. Furthermore, the research was funded by Vancouver Coastal Health, which operates Insight, the facility, so their outcomes may not be entirely objective. All we see happening is more and more addicts coming to Newmarket because now they know they can use the drugs and that people will make sure that they don't die. We don't need doctors to create a safe place for addicts to inject. We need doctors to figure out how to stop them from needing to. Thank you.
Thank you.
My name is Ben Murphy, and I am here today on behalf of Food Pack Express. We are a wholesale food company with 4 locations in the state, and we have been in Newmarket for over 20 years. We vehemently protest the city's use of our neighborhood as a dumping ground for all the unwanted facilities for which other towns do not take their fair share of responsibility. It is incomprehensible to me that anyone would think that lumping all services into one area can be a safe environment for anyone. Newmarket already contains 2 homeless shelters that together house almost 1,000 people each night. Additionally, approximately 1,300 methadone patients are treated every day in Newmarket. This concentration of at-risk populations in the area already attracts drug dealers who prey on the disadvantaged and the already addicted. Adding a safe injection site would only exacerbate this problem. Even in the best-case scenario, if the safe injection site did not attract any more addicts to Newmarket, it would not reduce the number of people on the streets once they left the facility after shooting up, since on average they are only in the facility for approximately half an hour. Our business has suffered enormously with needles all over our streets, robberies, vandalism, and harassment. A solution to combating overdoses is not to enable them. If we are serious about fighting the opioid epidemic, then stopgap measures like a safe injection site are useless for our ultimate goal of ending the crisis. Our efforts should be better spent on programs that directly combat addiction, not just maintaining the status quo. Thank you.
Thank you. And then following Lizzie, we'll have Sue Sullivan, Michael Rothschild, Bob Minocci, and Irene Corrales.
My name is Lizzie McLaughlin, and I'm here representing Newmarket Community Partners, a nonprofit in the Newmarket area focused on job growth and increased community employment. We have got to stop the enabling process. Instead of fixing the root of the problem, we are just enabling more and more similar behavior. Take methadone as a treatment. It is not fixing the problem, it is giving addicts an alternative high that they can live with. We need to deprivatize methadone clinics because patients are not being properly weaned off of methadone. Private owners do not have the incentive to make patients better when they're making a $5 profit per person every single day. We are at a point now that more methadone patients are on methadone for life than ever before. To stop the spread of disease, we started giving out needles. Now, we don't just give out 1 or 5, we give out 500 needles. Even though this saves lives, we are once again enabling and ignoring the root of the problem. Now we want to create safe injection sites where people can shoot up at will and know they're being watched over. Yes, it decreases the amount of deaths of people just using it in that space, but how many more people are using it because they know they won't die? In Vancouver, the safe injection site, Insight, is often touted as a poster child for success, when in fact we do not have nearly enough information and research about their progress. The root of most of the problem is the overprescription of opiates. In the United States is the largest per capita consumer of opiates. If you can even believe, in 2015, American physicians wrote 775 opiate prescriptions for every 1,000 people. Last summer, the U.S. Surgeon General wrote to every physician in the country asking for their help in turning the tide on the country's opiate epidemic. In his letter, Dr. Murthy signaled that overprescription was the root of the issue, spurred by decades of aggressive marketing from pharmaceutical companies. By allowing a safe injection site, we're sending the message that drug use is okay and that addicts do not have the capability to get off of the drugs. For all these reasons, we are completely opposed to a safe injection site in Newmarket.
Thank you. Sue, Michael, if you'll go the other side, it just, the queuing works up. And then do I see a Bob or an Irene coming down for, is Bob there as well? Very good.
Okay, so I'm Sue Sullivan. I'm the Executive Director of the Newmarket Business Association, and I'm here representing the 235 businesses and property owners that are in that 500-meter area surrounding the intersection of Massachusetts Avenue and Melnia Cass Boulevard, known as the Newmarket Industrial District. I'm going to shorten a little bit, even though I'm a little long, because a lot's been said already. But I'm here to tell you that the association is completely opposed to safe injection sites in Massachusetts, and more specifically, the siting of any kind of safe injection site in Newmarket. What you've heard from the last several speakers have been facts, and they've been facts culled by hours and hours of research. Okay, for several years, we in Newmarket have worked closely with the city and the public health department and the mayor to change the course of addiction and homelessness in our area that you know as methadone mile. We have been supportive of incremental steps, needle exchanges, outreach workers, the spot facility, okay? And today, we still have more and more people using drugs than ever before. All you have to do is walk around with me for a half an hour in Newmarket and look at the 50 used needles in the Clifford Park or the 200 used needles behind Bubbles Car Wash, or watch the person who just walked up to a car at the intersection, handed someone inside $10, and the person inside took a needle and put it in the gentleman's neck to give him a high right there at the intersection. I've seen that twice this week. Okay? The answer is not to enable them to do more drugs. We have some of the best minds in the world here in Boston, and you're telling me that the best we can do is to come up with a safe injection site solution? The Mass Medical Society should be ashamed. It should be ashamed that this is the best answer they can come up with. So right now, I and our 235 businesses and our 28,000 employees that we represent down there, we challenge everyone. We challenge the governor, we challenge the mayor, the legislators, and the doctors, and yes, we challenge ourselves right along with you to come up with a real solution. We need to figure out how to change the cycle of behavior. We need to figure out how to help our addicts and homeless to embark on a new way of life, and not to ignore this inhumane existence we see day after day on the streets of Newmarket and across the city and across the state. People sleeping on concrete sidewalks, people defecating in alleyways, and people impaired such that they weave into the streets in front of oncoming traffic. These people are dying in our streets, and we need to figure out how to change this. The answer is not to enable them to shoot up freely. A few years ago, we had to close the Long Island shelter. Now, the Long Island shelter wasn't perfect, but it certainly was a step in the right direction. It provided a broad spectrum of services in one place in a relatively enclosed setting. Like Steve Fox and our friends in the South End, we believe we should be able to perfect this model and design truly state-of-the-art campus-style facilities across the Commonwealth, beginning right here at that Shattuck Hospital area that Steve talked about earlier. The Mass Medical Society should be advocating for these locations where at-risk individuals can access low-threshold areas, addiction treatment, beginning from detox all the way through not just 30 days, but all the way to the next step and the next step, including temporary shelter and transitional housing and more. These facilities should have health services, both physical and mental. If all of our hospitals can have satellite offices to fix knees and shoulders and all in Dedham and Waltham and everywhere else, they should be able to work with our public health departments to create satellites in a facility such as this. But guess what? Everyone's going to say this costs too much. And everyone will say they don't want one in their community. In the end, it comes down to money and political will. There isn't one community in the Commonwealth where its citizens are not affected by opioid abuse. It's everyone's issue. Does the solution cost too much? What are we spending now spinning our wheels and advocating safe injection sites? It's not can we afford to pay for the right solution, but rather can we afford not to? Both the public and the private sector have to work together to make this work. It's all of our problem. I was brought up with a belief in treating the whole self. Not just how do we keep someone from dying at a particular moment at a safe injection site. Because I'll tell you that there are thousands of people dying out here every day. They're just not dead. One thing is for sure, they certainly aren't living. Can you really sleep at night knowing that we're not doing everything we can to make a difference, and the best we can do is provide a location where an addict can shoot up while medical personnel watch through a mirror to make sure they don't die? I can't. Thank you.
Thank you, Sue. I do remind everyone that I'd like 2 minutes, please. Michael?
Good afternoon. I'll be brief. Thank you for the opportunity to share some views on this topic. My name is Michael Rothschild. I'm the president of the Newmarket Business Association. I've been a business and property owner in the area basically my entire life and continue to work on improving the area for everyone that calls it home. In fact, my father was one of the original members that helped create the association that has assisted hundreds of businesses in the last 40 years. The NIC district is a vibrant, diverse business district with hundreds of businesses of all shapes and sizes. It is a vitally important light industrial district that provides many of the services upon which most of the city depends. While many of our companies are thriving, the burden they face grows constantly in light of the opioid epidemic that is ravaging our city and state. While the area strives to create thousands of jobs over the next 5 to 10 years, this task becomes more difficult every day with the focus being shifted to dealing with all of the adverse impacts from being located in such a drug-centric environment. Methadone Mile is a moniker that we are desperately trying to shed as our little area has become synonymous with methadone and drug abuse. What we have struggled with for over 20 years is a number of people coming in from all over the state for treatment, in quotes, that never seems to end. Every day our public health agencies struggle, costs escalate, resources get consumed, but the problem still grows. While the answers to this problem are elusive, to all, what will not be helpful is a safe injection site. This only perpetuates the problem and could attract addicts from all over the state and even beyond, especially if there is no registration process, as we've been led to believe. This program will be an absolute unmitigated disaster if allowed to happen in an area already overwhelmed with these issues. Rather than advocate for a safe injection site, we'd prefer to advocate for a real solution, such as the one we're going to be proposing at the Shattuck Hospital. The root causes are many. We all know them, both legal and illegal. I'm not going to get into them. But what we want to bring to bear and call to people's attention a little bit is the issue of the methadone problem that we face. Methadone has become a business. We've seen it from ground zero when it started 20 years ago, when it got legislated. It's become a very, very profitable industry, and it's a perverse incentive to keep people on methadone indefinitely. These clinics, the methadone clinics, make millions with no incentive to get people off. Many of them are owned by doctors and private equity firms. So I think we need to look deeper into the business of methadone and try to take the profit out of methadone and use it for better treatment facilities for the addicts that really need it. Thankfully, there are new treatments available in terms of drug alternatives and distribution mechanisms that have proven more effective than the current model. We don't need another program that enables addicts to use more and more drugs. We need to understand and cut off the roots of the epidemic. We urge you to make the hard decisions to actually change the cycle of addiction, and for our part, we're more than willing to be a partner in any way that we possibly can. Thank you.
Thank you. Irene?
Yes, I'm actually an attorney, and I'm connected with the church, and I'm connected with multiple businesses, including the taxi industry and the real estate industry. And, you know, my question to you is, if someone has the flu, they have multiple symptoms. For example, maybe a fever, maybe a cough, maybe a runny nose. And I feel that what's been going on is there's been treatment to the symptoms. Someone will go and take cough syrup to deal with the cough, take aspirin to lower the fever, use a tissue to blow their nose, and they're busy running around treating all the symptoms, but they don't take it from the top down and deal with what is actually causing the problem. So now the doctors will say, well, it's a bug, it's a virus, it's a germ. And honestly, I think it's a lie. And that's, I don't care if you agree with me or not. My feeling at this time, based on my life and based on the people I've spoken with, is as a taxi owner, there's a lawsuit going on right now against Uber because there's something out there that's considered electronic conspiracy that is causing problems within the business. And what it is the telephones and the computers are being used in order to deter business away from the taxi business and towards Uber. Now, I'm not here to argue that case because none of you really care, but I've also found that as an attorney, I've seen information that I'm attempting to send to someone be changed. I'm sending somebody 13 questions and they're sending me back my questions plus the responses, and they're indicating I only sent them 12 questions. Now, you might say to me that this is a bunch of bullshit, but if anybody watches the front page of the newspaper on March 8th.
So, Irene,
No,
I'm going to
finish.
pause you just for a moment because we're not going to use improper language in the chamber.
Oh, I'm sorry about
Second,
that.
I'd like you to get to your comment about this.
I'm getting to the point.
Quickly.
The point is, on March 8th, on the front page of every single newspaper, they were talking about problems with iPhone, there's going to be a class action suit. Problems with iPhone, then subsequent to that, they were talking about some kind of Homeland Security problem.
So,
that
Irene, I'm going to just interrupt you
impacted-
very quickly. Do you have a comment about
You didn't
safe
interrupt
injection
anyone
sites?
else, so let me finish what I'm going to say, whether you agree with me or not.
I would like to know that you have comments about
I am. I'm getting
safe
to
injection
exactly.
sites.
Yeah. And what I'm saying to you right now is this problem that is going on with computers and telephones has created non-trust in any kind of machinery. We don't have any trust in the hospitals. We don't have any trust in the diagnosis of people. People do not want to go and get diagnosed by doctors, and they feel that between the non-trust of the machines and non-trust of the earwaves, I don't really even want an opinion of a doctor anymore. I don't even believe that these people are being treated fairly. I consider them victims. I feel that they are being victimized in order for other people to make money off of them, and that they are being influenced by outside sources. And I think it's time for Boston City Council to unite with the state reps and go to Washington and say something about the way the people in Boston are being treated. We're being pushed around like robots, and it's being done electronically and through earwaves. And I don't care if you agree with me or not, but that's what's going on. And I don't believe that Boston City Council is responsible for it. I think that different organizations with different agendas are pushing their issues. I want to make money through the food industry. I want to make money through the medical industry. I want to make money through the lawyer industry at other people's expense. I'm not trying to say anything bad about the medical profession. I think that they're actually attempting to help people, and I know you're actually attempting to help people. I know the attorneys are too, but it's like treading water. It's like the Dutch boy sticking his finger in a dam, and it's a waste of time until some actual truth and honesty and respect for individuals and humanity is shown. And you're not going to be able to do it unless it comes from the federal government. So I'm asking you to do that for them and for cancer victims and for heart victims and for other people who are connected up to a machine and being told that they have something wrong with them when they don't.
Thank you, Irene.
So next we'll have Olivia, Megan, James, Cody, perhaps, Sarah, Casey, and Whitney. Olivia.
Hi, my name's Olivia Richard, and I'm setting a timer. So I'm a resident of Brighton. I appear to be the only wheelchair user in the room. And I experience a unique phenomena that the rest of you may not know, and that is what you get on your feet, I get on my hands. Needless to say, this opiate crisis has led to quite a few close calls with needles and such getting stuck in my tires. I'm a proponent of literally anything that will make a difference. I say if we're talking about sighting, heck, I would love to live next to one of these things. Because you know what? At least I would be next to something that's productive.
Thank you very much. You're very clear and concise, and I'm going to take a lesson from you and set my timer. Olivia, I appreciate that. Megan.
I'll try to be very quick, too. Thank you very much for having this. Councilor Presley, it was good to hear about your father's sobriety. I'm a nurse. I also live in Dorchester. I'm a nearly 20-year resident and a civic association president, past civic association president, and I'd like to speak in favor of the SIF. I currently work in the spot clinic that several people have spoken about, where we monitor people who have taken drugs until they're safe to leave on their own. We've prevented countless emergency room visits and probably some deaths as well. If the SIF opens, and I would be privileged to work there, I can tell you that my goals that I have in SPOT would not change. The goal that I have every day when I go to SPOT is to help folks who are using drugs to get stable, to be able to live, to be able to experience life, to have hope, to know that they're valuable. I try to tell each and every one of them, we love you. You have such a bright future ahead of you. What can we do to help you? Every single day we offer to make calls for these folks if they're ready to go to treatment. If they are ready and we make calls, there frequently aren't beds. On the days when there are beds available, and they want to go, we move heaven and earth to get them there. We cab them to Worcester, to Stoughton, to wherever there's a bed. I'll buy them cigarettes if they want cigarettes. I'll buy them new socks, candy, whatever they need to get into treatment, because I believe it works, and I believe that they all have so much to offer our city if we can help them get into treatment. I've frankly been appalled by many of the comments people have made here about the folks who hang out around Melnia Cass Boulevard. I can tell you from experience, I know many, many of them. They grew up in the neighborhoods where I have lived. They participated in the sports that I take my kids to. They went to Savin Hill Little League. They went to Sully's on opening days. And this is where they are right now. As a nurse, I will treat every patient who comes in with the dignity that they deserve. And I think part of that is to help them stay alive. This facility will help them to stay alive until we can get them into treatment. You know, when they leave us and they go inject and Target the bathrooms or McDonald's or wherever and they don't make it, there's nothing left for us to do. We can't offer them treatment. There's nothing I can do. And it's heartbreaking to me. And I think that as a city, we owe it to them and to their families to offer them every opportunity to live and to be able to get into treatment. Thank you.
Megan, thank you very much.
Hi, my name is Sarah Casey. I'm somebody who works with people who use drugs. And first, I would just like to say that people who use drugs matter. Their lives matter. And I appreciate all of the people here who self-identify as people who use drugs. Thank you for being here. And I'm sorry if this was at all offensive to you in any way. That being said, I had things written and then felt moved to let those stand alone and say things that kind of cropped up. I think it's important to acknowledge that as elected officials, you represent not only the taxpayer, but all of your constituents, and especially perhaps those folks who are not doing so hot. And that being said, people who use drugs can choose to use drugs for any number of reasons, and I think that a supervised injection facility simply allows people to do what they want to do in that moment in a way that is safe and healthy and supportive. I think your question about what do you say to folks who are afraid to let their children go to the park and run around in their flip-flops is, you know, like, folks who use drugs feel stigma and isolation, and if services were provided to them in a comprehensive, non-judgmental, non-shaming framework, they would access those services. People who use drugs also have children. They too want their children to run around in the grass, right? Like, providing services in places where people feel comfortable and able to go, I think is at the heart of this. People who use drugs matter. Thank you for your time.
Thank you, Sarah. And if you want to submit your other testimony, you're welcome to do that.
Thank you.
Great. Yep.
My name is James Cook. I work with the SIF Mass Now group. I have two quick things to say. I wish Councilor Baker hadn't left. He asked if there is a medically supervised alcohol consumption facility anywhere in the world. Yes, there is. It's operating in Ottawa, Canada, and it's actually extremely successful at mitigating harm in alcoholics' lives. And then the other thing is, I'd like to say, basically for everyone who has put forth this idea throughout all of this testimony today, that using drug users' lives against them to try to force them into a behavioral model that you want to see them in should be seen as a personal moral failing of the highest order and should never be allowed to dictate our policy. This is a written statement from James Shearer. He's the Boston resident, co-founder, and president of Homeless Empowerment Project and Spare Change News. He says, to the City Council, a few years ago, I lost a friend to an overdose that could have been prevented. Her name was Bobby, and she was an addict. She was also a daughter, a mother, a sister, a friend, a human being. We seem to forget that when we talk about people who use drugs, instead we see and treat them as far less than people. We're caught up in our moralistic superiority and can't even imagine that a safe injection site could save lives. Bobby could have been one of those lives. She had just been released from jail and almost immediately began to use. Of course, she overdid it and wound up in a shelter where there's very little in the way of medical supervision. The shelter personnel, not trained to spot that she'd had too much drugs and alcohol in her system, simply threw her on a bed instead of sending her to a hospital. Once they realized what was wrong, it was already too late. Now I know what you're thinking. Would she have went to the site if it was available? Perhaps, if only she had had that option. The bottom line is this: injection sites will save lives. People will be given a chance and treated humanely instead of accidentally overdosing in subway stations, bathrooms, bushes, and shelters without medical personnel. Remember, these are human beings, not just addicts.
Thank you. Will James be coming? I can take him off my list.
He was not able to make it today.
Okay. Someone signed him in, that's why I asked. Thank you. And then after Whitney, we have Dr. Mark Eisenberg, Dr. Irving Fernandez, and Judith Hudspeth.
Hi.
Hello.
I don't really know what I'm going to say, but I've been a heroin addict for 30 years. And I overdosed 11 times in January and February, beginning of March. And if I had had a safe injection site to go to, I would have gone. But I died 11 times. And they finally sectioned me. But I'm a human being, and I'm not going to stop using heroin. So for me, I need a safe injection site. I don't want to die in a porta potty. And my life does matter. It does. I help people every day. I do something good for my heart. That's all I have to say.
Whitney, thank you very much. Thank you for sharing. And do we have Dr. Eisenberger or Dr. Fernandez or Dr. Hudspeth with us?
Could I read on behalf of Dr. Eisenberg?
Yep.
So Dr. Mark Eisenberg is a primary care and infectious disease specialist out of Charlestown. I am a primary care physician and infectious disease specialist at MGH Charlestown Health Center, barely 3 miles from where we are meeting. In the last 2 months, I have lost 4 patients to opiate overdose deaths. I am sick and tired of attending wakes and funerals for those dying needlessly. We are in the midst of a true public health emergency that requires a radical rethinking of the way we are conducting business. Last year, more people died of drug overdose in Massachusetts than died of AIDS at the peak of the AIDS epidemic. Naturally, drug overdose is the leading cause of death in those under 50. In addition to prevention and treatment, we need to provide a safe place for people to inject who are not ready to stop their drug use. Keeping these people, our brothers and sisters and friends, alive and healthy until they are ready for help needs to be our priority. I recently visited Project Insight in Vancouver. They have demonstrated a myriad of benefits: a 30% increased uptake in drug treatment, a 35% decreased overdose rate, and a decrease in public injecting and syringe discarding. Multiple studies have demonstrated that this intervention will save money by preventing the infectious complications of drug use. Massachusetts has led the way in so many public health measures. Let's be a shining example to the rest of the country. Thank you.
Thank you. And if you'd like to submit those as well. Dr. Wally, Dr. Kim Sue, and then I have an AHOPE participant 1, or I. And then I also have H, AHOPE participant.
Did you call Dr. Fernando?
I did, but he,
Okay. Can I read speak for him, please?
yes, please. And then I don't mind if you want to submit after this the testimony of those that aren't here, because there are a number of people that are still here, and I want to make sure we get to them.
This written testimony is from a physician, Dr. Ira Fernando, who's an addiction psychiatry fellow at Boston University and a proud member of SIF MA Now. As the testimony from Mass Medical Society has shown, there is strong evidence that SIFs can not only save lives and millions of dollars from reduced infectious diseases, but it can also increase access into addiction treatment. I would like to expand on this point, as it is often not discussed in length. Working directly in the addiction field, I see firsthand the huge gap that we currently have in our treatment model. According to the National Institute of Drug Addiction, which is part of the federal government, addiction is defined as a chronic relapsing brain disease. However, when a person does relapse, either while at a residential treatment program or while taking medication-assisted treatment, there are many instances in which these people are then kicked out of treatment. At that point, where do these people go if they have no access to addiction treatment? SIFs fill this huge gap in our treatment model. SIFs give the drug user the opportunity to speak to an addiction counselor, which in turn develops a relationship of trust without fear of losing access to treatment. I do not believe I need to convince anyone in this room just how devastating this crisis is. I do hope we have the bravery to implement the solution that has worked so well from many other countries. Please allow safe injection facilities to provide the medical care that people so desperately deserve and need. Thank you, and please don't hesitate to contact me with further questions. Iru Fernando, psychiatrist at Boston University.
Thank you. Yep, please. And then
May
if
I
you would
read
introduce.
testimony from Dr. Kimberly Sue?
I want to see first if the AHO participant 1 or I is here.
I'm also reading for AHOPE 1,
Is
but I
there
also have my
H?
own testimony.
Is there AHO participant here? If you'd come down, please. And if you don't mind just holding, that'd be great. And then I also have Raquel, Tori Jenkins. All right, can we just wait till the end then? And then Bob King. Is Bob King here? Is Rich Fulham here? John Maston? And then John Sullivan? Jerry Scopentulo? George?
Carandinos.
Carandinos, is that you? Okay, you'll stay there, please.
Okay, I have two AHO participants, just statements.
If you would testify for yourself first. that
For
would
myself,
Be helpful.
Gary
Introduce
Langis.
yourself for the record.
Gary Langis, I'm an opioid historian. And I just want to get this back onto a harm reduction, because I've heard a lot about pharmacology and addiction and all of those things today. That's wonderful. But that's another hearing altogether. We're here to talk about harm reduction strategies and supervised injection facilities. And I'm going to go back a little in history, about 2005, when there was a picture on the front page of the Herald of a young gentleman in his 30s overdosing on the Commons. His picture was taken, plastered on the paper. The person died. He died later on. That was the last picture his parents saw of him alive. Okay, with the upticks in overdoses, we're seeing more and more people overdose in automobiles, in parking lots. We're seeing more people overdose in McDonald's, because we have injection facilities all over Boston. McDonald's, Dunkin' Donuts, all of those merchants there from the New Market, under their stairs, behind their trucks, that's the injection facilities. What does it do? Somebody overdosing in Boston Commons for our tourism. What does it do for tourism? I come from Indiana and I see somebody dying on the Boston Commons. My grandchildren walking home. I have 7 grandchildren. They're walking home from school, watching somebody injecting their car because they have no place else to go. I want to get in the bathroom at McDonald's, and I go in and I find somebody blue, dead, and overdosed. We're looking for something. Harm reduction is to reduce drug-related consequences of the individual, the family, and the community. We all have a lot in common. We want a healthy community. I want my grandchildren to be able to walk down the street. I want people I bring into Boston to visit to see a healthy community. I want, to go into a restaurant and not have to get stuck with a syringe that somebody had no place else to discard but in the restroom. I'm sorry, thank you for staying. Thanks for staying, because the other councilors that stated that the cherry picking stuff of 640 detox placements at Insight in Canada, that's on site, because they built the detox upstairs at the request of the participants that wanted to get into detox. They also refer out to a wide range of detoxes. Blood Alley was Death Alley 18 years ago. That's what it was 18 years ago. People overdosing on the streets. There's never been a documented fatal overdose in any injection facility around the world. Never. So, these are the 2 statements from the participants. H, a space to safely get high for reasons, life, less needles. He supports it 100%. Tori Jenkins, it helps prevent the spread of HIV and death. Thank God for AHOPE. I just hope you can really continue this conversation on, because we haven't even scratched the surface around supervised injection facilities in harm reduction. This isn't treatment. This isn't addiction services. This is trying to keep people alive, harm reduction. Reducing the consequences of drug use. Not what's the end result. The way it is now, keep it the way it is. The bathrooms will be used as injection facilities. Everything will be used for injection facilities. We have no place to go shoot dope, except for McDonald's, Dunkin' Donuts, in the alleys. And that's shame on us.
Thank you. If you would just introduce yourself for the record.
Hi, my name is George Karandinos. I'm a fourth-year MD PhD student at Harvard Medical School. But even before medical school, I saw the suffering of addiction up close. While, as an anthropologist, I lived for 4 years on an open-air heroin selling corner in the heart of Philadelphia's drug market, interviewing dealers, users, their families, and our other neighbors. Over those years, dozens of people died of overdoses in the garbage-filled train tracks immediately adjacent to my block. Sadly, a month ago, my friend, Paul Yaber, a committed activist, added his life to this tragic count. I know the very tracks where Paul was found face down among hundreds of discarded syringes. A bitter irony of Paul's death is that he was in the midst of advocating for a safe injection facility to replace the filthy, dangerous spaces like the one where he died. The thought that Paul could have safely navigated his relapse at such a facility is almost too painful to bear. In his relapse, Paul faced historically unprecedented risk given the fentanyl that has flooded the streets that is 100 times more potent than heroin. But let's be clear, there is no mystery to why fentanyl is taking over. It is the direct consequence of market pressures produced by drug interdiction under the war on drugs. Drugs have become stronger and more frequently synthetic because they are easier to smuggle and easier to produce. Acres of poppy fields have turned into small, easy-to-hide labs, and kilos of heroin have turned into grams of fentanyl. When we cracked down on marijuana, established smuggling routes were repurposed for the more compact, pricey, and deadly cocaine. Each Pyrrhic victory of the war on drugs has given us stronger, cheaper drugs, and their use has only become more deadly as a result. You cannot win a war on fentanyl, any more than you can win a war on any drug. A safe injection facility can reverse this trend, minimize the risk of relapse, and give people like Paul a fighting chance to stay better. Please let Massachusetts proudly lead this charge, especially now that fentanyl has made relapse so much more dangerous. I give you my deep gratitude for your attention. Thank you.
Thank you. Eileen Sullivan, Molly Duggan, Henry, oh, here. Daniel Hogan, Gary Langis, and then Dot, maybe? Yep. Oh, thank you. Thank you. Please introduce yourself for the record.
Yes, my name is Molly Dugan, and I'm here today to express my enthusiastic support for safe injection sites in Boston. As a social worker who specializes in addiction, I often work to educate my patients around overdose prevention. We talk about how to keep your equipment safe, how to do test shots, how to get access to Narcan, but one of the most important pieces we talk about is not using alone. People who struggle with addiction are used to hiding what they do for a lot of reasons, but a driving force is the shame that is reinforced by the society at large. My patients inject alone in locked bathrooms because they don't want to disappoint their families, friends, and coworkers. They use in secret because they have learned that asking for help brings about negative consequences. They lie about using because we criminalize their behavior when they're honest. Our systems make people want to use alone, and that stigma exacerbates the opioid crisis. What I've learned in doing this work is that people are going to do drugs. Some people want help with that, and some people aren't there yet. But a consequence is not great enough to deter someone if they are not ready to stop, and we know this because we know the overdose numbers from the past few years. So what if instead of punishing these people, we support them? We acknowledge that one way or another, people are going to use heroin and it doesn't make them unworthy of care, and we let them do it in a safe space. We let them come out of the alleyways and the public bathrooms and the rundown buildings they've been hiding in, and we connect with them, and we let them know that we care enough not to let them die. It might be radical and it might be something we haven't tried before, but if what we were doing were working, if drug courts and everything else that was referenced here today were working, we wouldn't be referring to it as an epidemic. I'm proud of what I do and I love the people I work with, and I'm willing to support anything that will make it easier for them to heal. There's no research that says by helping someone be safe, we make the problem worse. We have learned a lot from hearing about other safe injection sites already today, and I want to say that through this kind of support, we can increase the odds that someone will feel comfortable asking for help. Is this a perfect option? No. And will it be unconventional? Yes. But as a mental health provider who spends every day fearing that I will hear another person I care about has died, I'm tired of being told I need to stick to what's conventional. If you as an individual are uncomfortable with this idea, I encourage you to explore where that comes from and to ask yourself why your discomfort should outweigh the potential health benefits to thousands of our most vulnerable people. People have referenced the Long Island shelter today, or the Long Island services that were previously in place, as a popular idea because we liked the idea that we could put addicts on an island and not have to look at them. People like referencing the Shattuck because we can put them in a dilapidated state hospital where I worked for 4 years and not have to look at them. We need to be bold and we need to be kind to our friends struggling with addiction. Otherwise, we risk keeping them behind locked doors. I just wanted to say that I was disheartened to watch the conversation shift from a conversation about safe injection sites to a critique of already medically approved treatment, like Suboxone or methadone, or things that are effective to treat our patients. And it was hard to be encouraged that this body would be forward-thinking when we're not approving of what's already out there. Thank you.
Thank you, Molly. Just introduce yourself for the record, please.
Sure. My name is Dan Hogan. I'm a clinical social worker. I also have a master's in public health from Boston University, and I work in community health. Thanks to everyone who's present today, especially the New Market business representatives who've stuck around to work on this problem. I think it's imperative to our public health and humane to our patients, clients, friends, families, strangers, and individuals who are not even aware what an opioid yet is, that we come to some sort of solution for the problems that we're talking about. I'm sharing as someone with multiple perspectives on this issue. I work in community health and I support the individuals of the health of individuals who use substances. Many of the patients that I work with have been dealing with opioid dependence for much of their lives and are seeking treatment in our program. I'm sharing as someone who recently lost a cousin to overdose at age 28 after struggling with dependence most of his adult life, someone who grew up and I am someone who grew up north of Boston and have seen numerous classmates die following my high school graduation in 2000. I can't count how many friends and acquaintances I've outlived. I'm sharing today as someone who was dependent on heroin from 2004 to 2008, who never overdosed and who was fortunate to have been introduced to the philosophies of harm reduction at a young age. I don't know if that would have mattered as much if when I was using the more than 43 fentanyl-related compounds that we see in the drug supply today were as pervasive as they currently are. We train and distribute naloxone. It's not always potent enough. We enroll people on buprenorphine, naltrexone, and methadone, but they don't always sufficiently blockade receptors against fentanyl-related compounds. We teach people to use in groups so that if someone overdoses, another person can help. But we offer no safe spaces to do that. The places that people are able to do that, we call shooting galleries or crack houses. There are no nurses or social workers, physicians, or educators on staff, just drug users and drug dealers. I honestly can't think of one logical reason as to why we shouldn't embrace the idea of moving forward with services like this. It would reduce the burden on police. It would reduce the impact on retail owners. It would reduce the overall overdose rate. It would reduce the drain and trauma that our emergency medical services and hospital EDs face every day. It would reduce the presence of active drug use on the streets in view of children, reduce the number of discarded syringes in our parks, on our sidewalks, or thrown in city barrels and restaurant toilets. It would literally improve the lives of people who think that folks who struggle with addiction are despicable, while also improving the lives of the people who live with addiction at the same time. It would improve my life because I'd see less of my patients die. I'd have a place to collaborate with and to engage with or contact new patients. I would be able to provide education and outreach. It improved the day-to-day experiences of every cop, doctor, restaurant manager, park service worker, landscaper, janitor, tourist in Boston in a way that has evidence showing that it works. It would also be one more way to remember that just because someone is in a bad place in their life, they're still human and they're still worth some basic dignity, that they matter. Thanks.
Thank you. Gary, I think I have you, right? You're Gary? Yep, I'm just checking you off for further, you're on my list here. And then the Dot. William Smith. April Ogarkov. Bill Friel, maybe, or Fried. And then Michael Gilbert. It happens. Welcome.
Good afternoon. My name is April Ogarkov, and for some context before I begin, I am a certified addictions registered nurse at Boston Healthcare for the Homeless Program, a member of the International Nurses Society on Addictions, and a sister to an active IV drug user. I wish the full panel and audience was still here to listen to those who would be most affected by this bill. I'll try to be succinct with my 2 minutes. One of the arguments I heard here today was the not in my backyard argument, but I think you would want this in your backyard. For one, syringes. From an environmental standpoint, you are minimizing syringe waste in public spaces where animals and your children play. I can't count the number of times I've had to call A-Hope and sit and wait next to the syringe and try to direct traffic around these syringes. The second would be tax dollars. From a fiscal standpoint, safe injection sites save countless tax dollars. The latest federal report noted that Massachusetts had the highest rate of opioid-related visits to emergency departments. A hospitalization for one of the less serious complications, cellulitis, can cost anywhere from $6,000 to over $25,000. The medication to treat hepatitis C is $1,000 per pill. A typical course of treatment will last 12 weeks and run $84,000, plus the cost of necessary companion drugs. Some patients may need treatment for twice as long, and that's a lot of your tax dollars. And resources, because every time a 911 overdose call is placed, a full fire and EMS response is called. And think of all the resources that could be saved. Sorry, my tablet just, okay. The advocacy of safe injection sites is not the end solution, as some have said. As proposed by others here, we need to look at mental health and prescribing practices and access to detox beds. That still all needs to be done. This isn't the ultimate solution to end addiction. This keeps people alive so that they can even access the other resources that we're proposing. In my experience working in the city's health safety net, I often see my patients being pushed away from the street, pushed away from visibility, and pushed away from potential help if something should go wrong. In Massachusetts, nearly 2,000 overdoses occurred last year alone, up from 603 overdoses 5 years prior. Safe injection sites are, they're not, the argument is not versus other modalities, it's versus unsafe injection sites. Thank you.
Thank you. And then anyone else that had testimony to give on behalf of somebody who is no longer here or wasn't able to attend. And Aubrey, if you just tell me who you are testifying for so I can mark them as such.
Yes, I'm testifying for Raquel, a Hope participant, lives down on Mass Ave in Boston. She wanted to make sure it was heard. Safe injection sites should be made legal. 1, for lower overdoses, and 2, for safer injections and better vein care.
Thank you. And then, George, if you would do the same, just let me know who you're testifying for.
Great. I am testifying for Dr. Kimberly Sue of Massachusetts General Hospital in Charleston. Dear esteemed Boston City Council members, I am a resident physician at MGH with a primary care practice in Charlestown. I am here to testify that the opioid overdose crisis is at its worst ever, and this current death toll and tragedy are simply unnecessary. My patients are dying and traumatized by overdoses. I am powerless to help them or be with them all the time when they use, but we as a society together are not. I have just returned from a trip to Vancouver where I witnessed the public health and medico-legal response to their crisis. Simply put, the reason that people die of an opioid overdose death is that they use alone in houses or in bathrooms or on the streets. The chances of death after being found even after 10 or 20 or 30 minutes is immense. When people are using in a safe space where they can be monitored, the response time to life-saving therapy is immediate. In the years since Insight, Vancouver's supervised injection site was founded in 2004. They have had 0 overdose deaths in their facility. In the over 100 supervised injection sites around the world, there have been 0 deaths. The Health Ministry in Canada just approved several more supervised injection sites, given their clear evidence. Seeing how Vancouver operates, linking these sites to detox and short and long-term treatment facilities for addiction treatment, it is a simply wonderful thing. People use the facilities because the police were frustrated simply at finding people dead alone. The police in Vancouver are even calling for more prescription heroin because the street drugs are so contaminated and unsafe with fentanyl. And in fact, the area that the downtown east side drug use scene occupies has decreased over the many years, contrary to what many people have suggested. It is imperative that we start a facility here in the Boston area. This is our generation's HIV epidemic. The big difference is we have medications and an apparatus to stop this right now and evidence proving effective techniques. I plead with you, our elected officials, to stop these needless deaths. Thank you for your attention.
Thank you.
Thank you.
If you would introduce yourself for the record.
Yes, ma'am. My name is Michael C. O'Malley. I've been a man in recovery since February 25th of 2015. And what that means to me is that I have not used a drug or a mind-altering substance since February 25th of 2015. I'm also a proud member of the Libertarian Party here in Massachusetts, and we do support this measure. If I can just give a very brief personal testimony, I was somebody who is very pro-abstinence, very pro-abstinence-based policies up until 2012. And then one day I walked into A Hope on Mass Ave, and I remember walking in because I went to come say hi to Sarah Mackin, and I remember seeing a wall, and I'll still never forget it to this day. I remember looking at the wall, and I remember an African American man. I remember his eyes, and I'll never ever ever forget that moment. And I knew what those faces were for, and I knew they weren't coming back. And I've known ever since that day that harm reduction has a way to save those people's lives, and that those faces on the wall don't have to appear there. I'm somebody who has used your building as a safe injection facility in 2010. I'm somebody who's used our State House as a safe injection facility. I've used in numerous bathrooms surrounding this area, ma'am. And although I am somebody who, at the height of my use, being in Medford, probably would have never ever been able to use it, I go down to Mass Ave once a week now. And those faces keep changing. And those faces keep changing, not because they're getting into recovery and they're going somewhere great. Those faces keep changing because they're not coming back. 80% of our homeless population dies from fatal drug overdoses. If that happened to you or I today, imagine the way in which we would respond to that. We would do everything in our power possible to do it. So I personally will never understand the stigma that surrounds the public health policies with regards to drug addiction. I am a huge proponent of safe injection facilities. I've studied about 22 various studies from Germany to the ones in Insight, and you've been probably statted to death today on every form of database analysis possible. But I don't doubt without question this would work. 25 years ago, we questioned whether or not needle exchanges would work. I don't think we have any questions about the viability of how needle exchanges play out in our society today and how beneficial they are. But I will be reading the testimony of Dr. Alex Wally, who is from Boston Medical Center, BU School of Medicine. To the Boston City Council Committee on Homelessness, Mental Health, and Recovery, thank you for providing a public hearing on medically supervised injection facilities. I am unable to make it in person, but I want to express my strong support for a facility in Boston. I am confident that a medically supervised injection facility will reduce overdose deaths that otherwise
have occurred and linked many of Boston's highest risk and most vulnerable residents to addiction care and harm reduction that they would otherwise not be able to access. Since 2004, I have provided medical care for people with substance use disorders in Boston, first at Dimmick Community Health Center and primary care in the detox facility, then at Boston Public Health Commission's methadone maintenance program, and currently at Boston Medical Center's HIV primary care clinic and inpatient addiction consult service, as well as the methadone maintenance program at 23 Bradston Street. I am the medical director of the Massachusetts Department of Public Health's opioid overdose prevention pilot program, which since 2007 has trained and equipped over 60,000 people in Massachusetts with naloxone rescue kits, and has documented over 10,000 overdose rescues. Boston Public Health Commission's AHOPE program is the largest of the participating programs. Despite improving opioid pain medication prescribing practices, increasing access to naloxone rescue kits, and more access to evidence-based addiction treatment, overdoses continue to increase. This ongoing surge is largely due to fentanyl in the heroin supply. It is crucial that we continue to increase access to naloxone and evidence-based treatment, finding the vulnerable groups we are missing. A supervised injection facility is a demonstrated way to do that with strong evidence that it reduces overdoses and facilitates treatment engagement. Because the window to respond to fentanyl overdose is smaller, seconds to minutes, instead of minutes to hours with heroin and oxycodone, the only way people who overdose can be saved is if they are directly observed. A supervised injection facility would provide a place where people could be supervised, offer more harm reduction services, and gain access to effective treatment. A collaborative effort between the CDC and the MDPH looked at the surge in fentanyl overdose in Massachusetts and recently published its findings, which I have attached. In this investigation, findings indicate that persons using fentanyl have an increased chance of surviving an overdose if directly observed by someone trained and equipped with sufficient doses of naloxone. Optimally, this should be public health personnel with medical expertise and access to addiction treatment. Again, I welcome the City Council considering medically supervised injection facilities as an effective tool to address the surging overdose deaths. And I and Dr. Wally both thank you. Thank you, Councilwoman.
Thank you, Michael. Anyone else? We wrap up. Very good. So at this, I appreciate all of you who've stayed till the end, and we will adjourn this meeting. There'll certainly be so much more to come.